आप सर आप जले पर नमक छिड़क देते हो सर.
This meeting is being live streamed.
हाँ सर,
Great.
नमस्कार.
गुड इवनिंग सर, नमस्ते.
अभी नहीं सर, तो अपन 10 मिनट के बाद लाइव स्ट्रीम होगा, वार्निंग दे रहे हैं बस, ध्यान से बात करने के लिए. Already sir, they're good. Yeshwamurthy sir.
Good evening, Paul sir. Good evening, Chandramohan. Good evening, all of you.
Sir, namaskar.
Good evening,
Namaskar.
sir.
Good evening, sir.
Good evening.
Yeshwamurthy sir, all our Zoom meetings, central office is in Delhi, or where is it, sir?
Agra. Central office is in Agra.
So the
Our
primary
office
control.
address, office is in Delhi.
Sir.
But people work from Agra.
Keshavji, good evening.
Good evening, sir.
So you will be speaking first, and will invite the president,
Yeah.
Dr.
I'll do
Sagnis,
that.
and then you will play the video.
Yeah, I have told the central office to keep it ready.
Okay.
Good evening, sir.
Hi, Sumit. How are you?
Yeshwar sir, good evening.
Sir.
All
Good
good, sir.
evening, Harsha. Good evening.
Yes.
Only 3 minutes to go.
Yes, Surya Prakash.
Getting ready.
Hello, Chandramohan. Good evening, everybody.
Hi.
So on which platform is the meeting live stream, sir?
YouTube.
Okay, sir.
So no idea how many people have logged in.
65.
65.
No, that is on this particular Zoom link.
Whoever joins on Zoom, only it will reflect. It will not reflect on the YouTube. Later on, once the program is there, how many log in, YouTube will tell. But live is 65 now.
We don't know about how many have logged in YouTube. We have no idea about that.
Sir, primarily now, they can join only by Zoom. They cannot see directly.
No, you can see Chandramohan. YouTube also you can join.
YouTube live you can join.
Yeah, you can join live. You can join live.
By subscribing.
USI has got a YouTube channel.
Yes, sir. Can we by clicking that, can we go live with that?
Yes, you can go.
And that is open to
Can
public.
this program?
Yeah,
Can
it's
this
open.
program be seen some other time also, or only during the lifetime?
No, it
some
will
other
be
time.
archived and it will be available on the website, USI website.
You can't see directly from the YouTube.
YouTube also you can see.
YouTube,
It's
once it
always
is
there.
open,
It's stored in
Yeah.
YouTube.
Yeah.
Yes, sir. YouTube it is.
Good evening,
Yeah.
everybody, and welcome to the first meeting of the Urolithiasis section of the Urological Society of India. I bring greetings from the Urological Society of India. This webinar was supposed to be held physically on the same date in Hyderabad when all the conveners had planned a very good program, but circumstances made us that we had to convert it into a webinar because of our upcoming USICon. And the conveners were very magnanimous in agreeing to that. But you will have a very big scale meeting in the coming year in May. Probably they are planning it in May. But this section was the most vibrant section of all the sections of the Urological Society of India. When we started the enrollment for the subsections, this was the section which was very active in getting the members enrolled. And right now, this is one of the largest sections of the Urological Society. Of the 6 sections, this is the largest section. So I thank all the conveners for putting this program together today about management of Staghorn calculus. All the stalwarts of the stone management in India are there on the webinar, and they will be sharing their views about various topics. I hope it would be interesting to all of them. Dr. Subnis is actually traveling, so he has sent in a message that he has sent a recorded message, and he would welcome all the delegates with his recorded message. Over to the central office to play the recorded message of Dr. Subnis.
Dear friends, as a president of Urological Society of India, I welcome all of you for this Urolithiasis section's inaugural meeting happening virtually. Stones are very common in India, and in fact, urologists are recognized by their ability to treat stones endoscopically. Obviously, therefore, urolithiasis is the largest sections of USI. Since now the subspecialty sections are formed, it is the responsibility of the office bearers to understand the need of the members and provide what they want. There is a huge potential to take this section to a greater heights. I know that the conveners had planned the nice physical meeting with live operative workshop, but with the special request from USICon organizers, we converted it into a webinar. Today's program is well crafted with some important topics which have the practical utility. I'm sure all of them will be useful to everybody who is logging in. I wish a great success to this webinar, which starts urolithiasis section's ball rolling. Thank you very much.
Thank you, sir. Now I would request the convener of the urolithiasis section, a very senior urologist, Dr. S.K. Paul, to introduce the session and take over the session. Over to you, Dr. Paul.
Thank you. Good evening, ladies and gentlemen. I extend my heartfelt warm welcome to all of you for joining in this inaugural charter online meeting of Urolithiasis section of USI. On behalf of group of conveners, including myself, Dr. Harpreet Singh, Dr. Chandramohan, Dr. Harshvardhan, I put on record our sincere thanks to each member of Council of USI who have given us this opportunity to conduct this meeting on this platform. Staghorn stones have always intrigued the urological fraternity. Its complete removal gives us immense professional satisfaction, but they recur. They continue to recur. All urosurgeons of my age group must have experienced repeated PCNL on the same kidney for recurring stones several times. My maximum is 6 PCNLs on the same kidney over 28 years. I thank my patient who continued to have faith in me and continued to come to me for his subsequent PCNLs. About 10 months ago, I performed bilateral PCNL on my 24-year-old patient for Staghorn stones for the 3rd time in last 6 years. He was a confirmed case of type 1 primary hyperoxaluria. Through his metabolic workup, we had confirmed it 2 years ago and started him on the lumasiran oxlumo injections, as well as heavy doses of thiazides and B6, vitamin B6. But within 2 years, he found the stones again. This time again, he had bilateral Staghorn stones, but his creatinine was ranging between 2 to 3 and he was managing somehow. This time, when I did his PCNL, he did not respond. His kidney function did not improve. Rather, it deteriorated. He developed symptomatic CKD and needed frequent hemodialysis. His family could afford, and he is my first patient of primary hyperoxaluria type 1 who has undergone simultaneous liver and kidney transplant 6 months ago. I wish him good luck and will keep a regular follow-up informing you time to time. I don't know how many of your patients have already undergone this liver and kidney transplant for primary hyperoxaluria. Death after PCNL or any stone surgery is unusual and usually unheard of. I started doing PCNLs in 1986 and had the first bad luck in 2004 of facing a death on 5th post-op day of 80-year-old boy after PCNL for his Staghorn stone. He was a very poorly nourished child of a laborer who died of sepsis after PCNL in ICU. Dr. Chandramohan has finished more than 8,000 flexible ureteroscopies, and fortunately he has not reported a death so far. But I was unlucky again 3 months ago when I lost a 76-year-old female patient on her 10th post-op day after removing her Staghorn stone from only functioning kidney. This lady had diabetes, CKD, and on the top of it, she was suffering from interstitial lung disease, and she was continuously on oxygen. Since she developed 2 episodes of UTI, needed hospitalization twice in last 6 months, we somehow decided to plan for a PCNL on her. PCNL was done with all due precautions with the sterile urine. She was discharged on 10th post-op day. Everything was smooth, but after 20 days when she did not come back for removal of her stent, when my assistant called her, he was told she is no more. On 10th post-op day, she succumbed. I don't know the reason. I did not have the courage to talk to the family and ask how and when and how the death took place. So Staghorn stones should not be taken lightly. They are not just bigger stones. They form a different disease entity and have to be looked after accordingly, and hence we are going to conduct this symposium. I am sure there will be a subset of Staghorn stones which should not be touched upon. Neither they will benefit the patient nor the urologist will get any reward. Situations may arise when urologists will think again, I should not have touched this case, should have left this patient alone. So we have also included a topic, is there a place for conservative management of Staghorn stones? Without wasting much time, I will invite the moderators of the first session, Dr. Vijay Bora from Agra, Dr. Shailesh Kamath from Goa, Dr. Pramod Kumar S from Kolkata, and Dr. Srinivas from Telangana to take over and start the first session and introduce the symposium, introduce the speakers and the topic. Over to the moderators of first session. Please carry it on. Dr. Vijay Bora.
Thank you, sir. For this session, the first speaker is Dr. Abhijit Patil, and the topic is how to manage Staghorn calculus in a patient with CKD. Dr. Abhijit Patil, please.
Am I audible and visible?
Yeah.
Yes,
Go
very
ahead,
much.
go ahead.
Okay. So I would like to thank Urolithiasis subsection of US and USI for this opportunity. Well, the first topic is how to manage Staghorn calculus in a patient with CKD. So it is more of a decision-making talk. So the flow of talk would be definition, incidence, how does Staghorn stone cause CKD, challenges in Staghorn management, especially in CKD patient, preoperative planning, optimization, management, and literature support. So what is Staghorn stone? So Staghorn stone by definition is a renal pelvic stone with extension into renal calyces. And what is CKD? So CKD is any GFR less than 60 for a duration more than 3 months and or a marker of kidney damage, especially albuminuria. So what is incidence is that infections on or steroid lead to an obstructive nephropathy with Staghorn calculus, another leading cause of ESRD attributed to stone disease. CKD represents 0.8 to 17.5% of those presenting with urinary stone disease. ESRD, that is end-stage renal disease, attributed to kidney stones is relatively modest, but with an estimated prevalence of 3.2% among the patients who start with maintenance hemodialysis. And 1.9 to 7.7% of the patients who undergo PCNL have CKD. Now let's see what are the mechanisms of CKD in stone formers. So it is multifactorial. The first being obstructive uropathy, second being recurrent UTIs in these kidneys, frequent surgical intervention as Pal sir said, and coexisting medical disease in these patients. So the first being obstructive uropathy. So this obstructive uropathy leads to a renal vasoconstriction and inflammation, leading to fall in renal perfusion, leading to renal ischemia. And if this ischemia persists long enough, leads to glomerulosclerosis, tubular atrophy, and interstitial fibrosis, leading to CKD. Complete urinatal obstruction for 24 hours, especially in that model, led to irreversible loss of function in 15% of nephrons. And if the kidney stone causes recurrent UTI episodes of obstructive uropathy, there is substantial loss of function in nephrons. Though the remaining nephrons may hypertrophy or hyperfilter, but over long time, these overworked nephrons may fail, leading to detectable CKD. The other aspect being recurrent pyelonephritis, the urease enzyme and the resultant high urine pH by this microorganism may contribute to kidney injury. The deposition of calcium oxalate crystals in the interstitium may also cause fibrosis. So these are all the various mechanisms that lead to CKD formation in Staghorn stones. Now, what are the challenges of this management of Staghorn stone in CKD patient? Is these patients have low hemoglobin, they have platelet dysfunction, they have infection, and fluid and electrolyte management, especially in the perioperative period. So what should be our aim and objective? So our aim and objective of treating Staghorn formation in CKD patient should be so effective that the renal function either improves or it remains the same and does not deteriorate. So this stable phase can avoid the need for RRT in future with minimal complications, especially in terms of bleeding and infections. Now, how do we take a decision? So here is an old paper way back in 2003. So we evaluated the Staghorn patient right from 1991. So the primary surgical treatment of renal calculus in CKD patients, around 84% was PCL in 87 renal units, nephrolectomy 7 units, and nephrectomy in 2 units. What we found is that PCL with respect to nephron loss is well established. We found that PCL is safe in patients with renal insufficiency, and there is no correlation between the number of tracts required for calculus clearance and renal function. So now how do we take a decision? So there is an confounding factor of an acute obstruction. So we de-obstruct it by putting a nephrostomy tube. We wait for nadir creatinine. And what we found is that the preoperative baseline serum creatinine was an accurate predictor of postoperative renal function. Especially 92% of the patient who achieved a nadir creatinine of less than 2 recovered well, as opposed the prognosis for patient with a serum creatinine of more than 6 was poor, with all 5 such patients in our series progressing to end-stage renal disease in spite of you do anything and requiring maintenance hemodialysis within 16 months. And what were the factors predicting the outcome in these patients was proteinuria, atrophic cortex which is less than 5 mm, recurrent episodes of UTI, stone bulk more than 1500 square millimeter, and pediatric age group, of which the most sensitive parameter was atrophic cortex followed by proteinuria. Now let's see, based on this module, various clinical scenarios as to how to take a decision. Suppose in case scenario, we have a 45-year-old male complaints of left flank pain, vomiting, fever for last 3 to 4 days. Ultrasound shows bilateral moderate hyperosis with left Staghorn kidney and a right small kidney. And serum creatinine was 13.2 with hyperkalemia and acidosis. And this is the left Staghorn calculus and left pleural effusion. So we placed two nephrostomy tubes, one in lower calyx and upper calyx, and the dialysis was done. And the renal function improved and was stabilized at creatinine of 1.7. Now this was the first stage, second stage, and at the end of third stage, we could completely clear the stone. And though this case requires 7 tracks, 7 punctures, final hemoglobin 8.3, but the final creatinine was 1.5. So what it found is that our nadir creatinine reach was 1.7. So we could have a good outcome in this patient. Now coming on to the second clinical scenario is a 65-year-old male, no comorbidity but a recurrent stone formers. Now complaints of weakness, left flank pain with fever, chills, and repeated episodes of surgeries on left side, left open lithotomy 20 years back, left PCNL, left URS 814. And now again patient came with right Staghorn stone with a small contracted kidney on right side and left gross hydronephrosis. Hemoglobin was 7, counts were raised, living parameters normal, creatinine was 18.34, field pack of first cells, and urine culture was E. coli. This was the picture, but on CT, this was a small contracted right kidney with a dilated left kidney and some small lower calyceal stones. So what we do is that we did a PCN on that side, a frank puncture at frank person came, and the creatinine settled to around 8. So so as we said, if the creatinine after nadir creatinine is more than 6, the patient will end up in RRT, and that is how on follow-up the patient landed up in IRT. So in these patients, if there's no episodes of recurrent UTIs, it's better to leave off this stone. Coming on to scenario 3 is a 65 diabetic and hypertensive, complaints of fever with mild left flank pain, creatinine of 9, left Staghorn stone, left PCN was put outside, came to us for further management. Now the creatinine is around 6, PCN output is around 500 to 800, and per urethral is 50 to 100. Now again, as I said, CBC is 6.1, creatinine is 6.0. Now urine culture is sterile. You can see the left side Staghorn stone was there with an ounce-full unit of around 800 cc. So this patient underwent a preoperative hemodialysis. Per urethral was 50 to 100, PCN was around 500 to 900. So because of good left PCN output, patient instead of stone clearance. But what we understand is that if the nadir creatinine is more than 6, we told him that we will do PCNL as you insist, but you will not be relieved of hemodialysis. Patient underwent PCNL, but immediate postoperative creatinine settled at 6 and slowly increased to 8 to 9 in the next 6 months, and patient is still on hemodialysis. So this will tell you what would be the outcome of the patient and how do you take a decision in patient with Staghorn on CKD. So now how aggressive you have to be in treating these patients. So this is an old paper from Journal of Urology by Marshall Stoller and Mantu Gupta group way back in 1994. At that time also, they had aggressively treated these Staghorn stones by whatever means they had PCNL or nephrectomy, and they found that the post-operative creatinine was actually better than the preoperative creatinine. This is their preoperative creatinine. Even if the creatinine is 2 to 3, it's significantly better. And even if it is more than 3, there was significant improvement in the creatinine if they treated these patients. Now, what is the impact of PCNL? As majority of these patients have treating modality as PCNL. This is again our institute paper, which 91 CKD patient underwent PCNL in 117 units. So there's complete clearance 83.7%, auxiliary portion 2.5%, complication rate of 17%. So the bleeding complication requiring transfusion around 6%, that is 1.7% renal units required super selective ambulation. But we conclude that PCNL has a favorable impact in CKD patient with good clearance rates and good functional outcome. So what we found is that we did a multivariate analysis to find out some clinical factors to predict RRT in future. These factors were renal parenchymal thickness, as I said, if it is less than 5 mm, postoperative complications, and peak GFR at follow-up. So as you can see, the GFR of the patient, once we put an PCN, it improves, and by the time we did a PCNL, this was the peak eGFR. So this is how they improved after we treated these patients of CKD with Staghorn. And what was the outcome is at a mean follow-up around 1 year, CKD down migration, stage down migration around 35%. Stabilization was around 51%. So majority of the patient either stabilized or they downgraded. Deterioration was only in 13%, 13% of the patients, and 9% of patients either went on hemodialysis or transplant. Now, various studies, even from India, stating the safety and efficacy of PSN and CKD patients is this institute paper, which has a sample size of 185. On the last follow-up, the mean creatinine was around 1. The improvement was seen in 62.2 patients, slight improvement in 37 patients. Deterioration was only in 0.5% of patients. So PCN associated with favorable functional outcomes in CKD, including severe CKD stage 4 and 5. Again, this is a paper from KGMC Lucknow, which said that there is improvement in GFR in 38 patients and improvement in GFR with state migration in 7 patients. So this was systematic review. At the literature review showed many papers who underwent PCL for Staghorn CKD patients, and all studies said that overall their patients eGFR or creatinine improved after they managed the stones. This is a paper from Keshavamurthy sir's group, and with a follow-up of 180 days, there was deterioration in 21 patients, 21% of patients. 10% required maintaining hemodialysis. Post-operative bleeding was only in 20% of cases. 5% required intensive care units. There was no mortality. So they concluded PCNL in CKD patients safe, and peak eGFR less than 30 and post-procedure complications predicted deterioration and need for RRT in the study. Now, how do we do a preoperative planning in this? Is we need to have a NCCT, as they cannot go on a CTIVU, and a 3D reconstruction, and something which is known as stone morphometry may be helpful. Is you can divide them depending on a favorable calyx which has an so once you decide an entry calyx, and depending upon the angle from the entry calyx to that certain calyx, if it is acute and if the infundibulum is less than 8 mm, it is an unfavorable calyx, and if the angle is obtuse or the infundibulum is more than 8 mm, it is a favorable calyx. So as you can see, you can divide, this could be the entry calyx, this is your pelvic stone burden, this may be an unfavorable calyx, or as opposed from if you go from this to this and this. So this is how you can find out the stone volume in each of the calyx, your entry calyx, pelvic stone burden, and your favorable versus unfavorable, and you plan your punctures well in advance so that these patients have very less reserve. So your preoperative planning need to be very important so that you have minimal bleeding in these patients. Now, what are the points to be kept in mind when you do a PCL, especially in CKD patient, is that an aggressive approach with multiple tracks and session does not affect the renal function. All effort should be made to completely clear the stones, to eradicate foci of infection and residual fragments causing obstruction in future. Prior nephrostomy dredging is essential as it improves renal function, reduces existing infection, and creates a mature tract that decreases bleeding episode during PCNL. Staging of PCNL is mandatory to keep the nephroscopy time low. The pelvic component of the stone is tackled before the calyceal component. It causes earlier complete liver obstruction. An Amplatz sheath is used to reduce the renal pelvic pressure, and reduced renal pelvic pressure decreases fluid absorption and subsequent bacteremia in these patients. So as Sir said, Staghorn stones already have an higher chance of sepsis, and CKD patient are already immunocompromised patient. So we have to be very careful while dealing with PCNL in these patients. So every effort should be done to reduce the bleeding complication, which the maneuvers would be ultrasound guided punctures, use of balloon dilatation, reduce and optimize the operating time, and stage the process, especially in large burden, reducing the tract size in non-hydronephrotic kidneys, especially with narrow infundibulum and secondary tracts in multiple tract procedure, may reduce blood loss during PCLL. Steps to avoid post-operative infection. So basically, you have to take care of bleeding complications and infectious complications. How do you tackle with post-operative infection is to adequate pre-PCL drainage of the PCS and administration of sensitive antibiotic preoperatively to reduce the pre-existing infection. Complete clearance of stone is essential to remove all the infective foci from the system. Now, careful post-operative irrigation, especially through nephrostomy drain or a retrograde uretary in this patient may help. If the intrapelvic pressures rise during irrigation, it may lead to bacteremia. So efforts should be taken to reduce hospital-acquired infection. Finally, a good understanding of impaired functioning kidney, safe operative techniques, prevention of complications, strict follow-up to prevent recurrent infections and stone recurrence. All these points have to be taken into mind when we treat a Staghorn patient in CKD. Will go a long way in sustaining the renal function in this patient. And some newer modalities that may help is
Dr.
addition
Abhijit,
of,
can you kindly conclude your this?
yes. So especially if you have a larger Staghorn stones, nowadays there are improvements in the delivery system. So even with mini perk, so what you can do is with mini perk, your track size is less, and with the help of newer devices like shock pulse or trilogy, so this will take care of your bleeding complication, and the suction component of these systems will decrease your intrapelvic pressure and take care of your bacteremia. So these devices in one track in mini perk can help in decreasing your further tracks and can help in managing Staghorn stones in a better way. So this was a demographic of our 250 patients of PSNL in Staghorns in CKD patients, and around 39% improved, 40 stabilized, and 21% deteriorated. So finally, to conclude, is to improve the renal function, control the infection preoperatively, stabilize comorbidity as they may be anemic, diabetic, hypertensive, or ISD. A proper anesthetic management, perioperative management, very important. The patient should have a stone-free status with minimal morbidity, and we should aim for prevention of recurrence. And we should be helping and consulting the family for further prevention of these stones, especially in this category. Thank you.
Thank you, Dr. Abhijit. Thank you very much. We'll take the question after all three talks. Dr. Shailesh, please introduce the next speaker. Dr. Shailesh. Okay. The next speaker is Dr. Rajkumar S. from Ranchi. The topic is precaution and management of infection in a patient with Staghorn calculus.
Yeah, can I introduce Dr. Rajkumar?
Yeah.
Dr. Rajkumar is doing private practice in Ranchi. He has published 16 national and international publications. He got first place in paper presentation at UAA, Kuala Lumpur, Malaysia in 2019. Operated on laparoscopic ureteric reimplantation at live operative workshop of East Zone UCI midterm conference, and he has presented papers in various conferences like PERCON and zonal conferences. May I call him to present his next talk?
Thank you, Shailesh sir. Am I audible and visible also?
Yeah, go ahead, please. Go ahead.
Yeah. First of all, I would like to thank USI Urolithiasis division for giving me this opportunity to present my presentation. My presentation is precaution and management of infection in a patient with Staghorn calculus. As just Paul sir has shared his experience, mortality is very unwanted thing, and it is a nightmare in the life of any urologist. So it's better to take lots of precaution, as well as better to manage these infection in a patient with Staghorn calculus. So definition already told, any branch stone occupying more than 1% of collecting system, that is renal pelvis with one or more calyceal extension, is known as Staghorn stone. What is the most common composition of Staghorn stone? It's a mixture of magnesium, ammonium phosphate, and this is also known as struvite stone. So we can say the most common Staghorn stone is also struvite stone. Other composition are calcium carbonate apatite, cysteine, and uric acid may form. And it's rare to see oxalate stone forming Staghorn shape. These struvite or calcium carbonate apatite stones are also known as infection stones. And there has been seen that there is strong association with UTI caused by urease producing bacteria and these type of stones. And these bacteria promote the generation of ammonia and hydroxia from urea. So this is the pathogenesis. High ammonia concentration by urease producing bacteria cause alkaline urinary environment, and it promote crystallization of magnesium, ammonium, and phosphate, that is struvite large branch stone. So UTI, repeated UTI with urea splitting organism may result in stone formation, and once an infection stone is present, infections tend to recur. So we can say that this Staghorn calculus, most commonly struvite stone, is very, very, very closely associated with the infection. That's why these stones are synonymous with infection stones. So there are some studies which showed that culture of infection stone fragment obtained from both the surface as well as inside of the stone have demonstrated that bacteria reside within the stone, thereby causing the stone itself to be infected. And stone made up of other substance like uric acid, cystine, where the stones remain sterile inside. So this gives idea that when you fragment these type of stone, bacteria comes out from the stone and may cause bacteremia as well as systemic infection. So there is a study by a Cross Group's Clinical Research Office of Endourological Society. They reviewed the incidence of UTI, post-operative fever, and risk factors for post-PCNL fever from 96 centers from the globe. And total of 5,803 patients were examined, out of which 16.2% had a positive pre-operative urine culture, and the most common bacteria isolated was E. coli. Post-PCNL fever was noted in approximately 10% of the cases, although the patient received antibiotic prophylaxis. This means even in those patients where antibiotic prophylaxis was given, post-PCNL fever was noted. The percentage of post-PCNL fever in patients with negative pre-operative urine culture and positive pre-operative urine culture was 8.8% and 18.2% respectively. Fever post-operative. Fever was seen most common complication in 21 to 39.8% of the cases. And they have taken the cutoff point of fever 101.3 Fahrenheit, and that is 38.5 degrees Celsius. And the study reported that 39.8% of patients develop a fever within 24 hours of PCNL. But beyond 24 hours of PCNL, this rate fell to 13%. And urosepsis and septic shock were found in 0.3 to 9.3% of patients who had a fever complication. But the mortality rate, we all know, is very high if patient develop urosepsis and septic shock, and that ranges from 66 to 80%. Again, in this study, specific risk factor was that are associated with post-operative UTI was found, like positive intraoperative urine or stone culture, infected stone, neurogenic bladder, high operative time, that is more than 120 minutes, and post-operative nephrostomy tube placement. So these are the factors which is associated with post-operative UTI. So regarding prophylactic antibiotics administration in PCNL, we all know that PCNL is choice for these Staghorn stone, as told by my previous speaker. PCNL comes under clean contaminated as well as contaminated type of surgical procedure. Clean contaminated, like uncomplicated stone without any obstruction, without pre-stenting, and without history of UTI. Contaminated procedure like complex stone with obstruction, nephrostomy tube already placed, double J stent already placed. And in both these type of surgeries, prophylactic antibiotic are recommended. Role of prophylactic antibiotics, despite the negative preoperative urine culture, it has been found that we should give perioperative antibiotic routinely. The role of prophylactic antibiotic is to only decrease the risk of post-operative infection complication, and they do not completely eliminate the risk of infection. Even if you give prophylactic antibiotic, this means that now the patient is free from any infection. In future, he will not develop any infection. It's not like that. So this type of patient may develop infection. Peri-procedural IV antibiotic are administered to reduce local wound and systemic infection. So prevention of infection, according to EAU, they have issued a recommendation that long-term or short-term antibiotic therapy should be given to all the patients with infection stones. And AUA has also recommended that all Staghorn calculus should be assumed to be struvoid, that is infection stone, and should be treated with prophylactic or suppressive antibiotic therapy. However, currently there is no high-level evidence for a specific antibiotic regimen. And every hospital has their different antibiotic regimen that they are using. Every urologist uses their own combination of drugs based on the this flora of their hospital. So according to EAU guidelines, they recommend administration of one of the following in all the cases of the Staghorn calculus that are going PCNL. These are the antibiotics name that they have suggested: trimethoprim, sulfamethoxazole, cephalosporin second or third generation, aminopenicillin or beta-lactamase inhibitor, and fluoroquinolones. And which should be continued, these antibiotics should be continued for at least 4 days post-operatively. So this is a good visual abstract which I found in the British Journal of Urology International. This paper was recently published in 2019, where this complex kidney stone PCNL was done. And what they found that if they found independent risk factor for the urosepsis after PCNL, operating time more than 100 minutes. If pre-operative in routine urine analysis, WBC is present as well as nitrite positivity is there, then there is very high chance of urosepsis after PCNL. Then if urine culture as well as stone culture is positive, then these are the patient where the positivity or chance of urosepsis is very high. And they found 2.4% patient develop post-operative urosepsis in Staghorn calculus. So what are the risk factors for urosepsis after PCNL according to this study? Pre-operative leukocyte elevation, positive urine nitrite, and positive urine culture. These are independent risk factors for urosepsis after PCNL. So we should look for these parameters before we are doing PCNL in case of Staghorn calculus. So recognition of early sepsis. So you have treated the patient of Staghorn with the PCNL. So what are the parameters you should watch for the look for to recognize early sepsis? Sepsis is basically, there are 3 terms that we are using in this type of patient: SIRS, systemic inflammatory response syndrome, severe sepsis, as well as septic shock. So what are they? SIRS, when temperature is more than 100.4 or less than 96.8, heart rate more than 90 per minute, respiratory rate more than 20 per minute, WBC count is more than 12,000 or less than 4,000. If severe sepsis, when BP is also start falling and systolic BP is less than 90, or a drop of more than 40 mmHg from the systolic BP is also considered as hypotension. And then there is lactic acidosis. Then when we call the patient is in septic shock, hypotension is there when BP is less than 90 despite fluid resuscitation. So in a post-operative period, when BP has fallen down and you have given the bolus IV fluid and his BP is not rising, you must be alarmed. And this is a septic shock picture. So recognition of early sepsis, there is a concept of golden hour when early aggressive treatment of infection has been shown to lead the better outcomes. Early antimicrobial administration within the first hour of hypotension from the septic shock led to higher overall survival. So this golden hour must be recognized by us, and we must give the antimicrobial different combination of antimicrobial drugs and bolus IV fluid as well as inotrope within this golden hour. If high risk patient,
can you please conclude?
Yes, 1 or 2 slides are there. If high-risk patient could be predicted, then close monitoring, aggressive fluid management, and early broad-spectrum antibiotic with ICU could be targeted. So there is a one concept, bundle 1 hour concept. Here, within 1 hour, what we are looking for, lactate management, blood culture should be sent, broad spectrum antibiotics should be started, IV fluid should be given, and early use of vasopressor if the blood pressure does not respond to fluid replacement. And there are 3 principles of treating infection stone. Goal should be all stone burdens should be removed. Stone should be removed surgically, and PCNL is the first line. And also important to recurrence should be prevented. So to conclude, urosepsis is one of the most serious complications following PCNL. Even in preoperative sterile urine, urosepsis following PCNL may occur due to release of bacterial endotoxin as well as viable bacteria during stone fragmentation. And there are 3 rules of management. At-risk patient should be identified preoperatively, give aggressive perioperative antibiotic treatment, monitor closely for septic complication during the convalescence period, utilize golden hour for early recognition, and 1 hour bundle for early treatment of these patients for good outcome. Thank you, sir.
Thank you, Dr. Rajkumar. Thank you for a nice talk. Dr. Pramod, can you please introduce next speaker? Dr. Pramod, are you there?
Yeah, I'm there, sir. I would like to now introduce the speaker for the third talk of today's program. The third talk is on is conservative management possible in cases of Staghorn calculus. This talk will be presented by Dr. Ritu Verma, who is working as consultant urologist at Sakalkar Lotus Specialty Hospital in Ahmednagar in Maharashtra. She is a recipient of USI International Travel Fellowship of 2020 as well as 2021. And she is also a winner for knowledge series of genitourinary cancer year in review quiz for 2021, fifth advancement endourology quiz in 2022, and Madras Urological Society Inter College Euro quiz in 2022. Now may I ask Dr. Nitu Verma to kindly present the talk.
I will start.
Talking to you.
A very good evening to all. My topic for presentation is conservative management possible in a case of Staghorn calculus. So there's a paper which was presented in 1970 by Blandy and Manmeet Singh. And according to that paper, the notion had come that once you identify that the patient is having Staghorn calculus, the only treatment available for that stone is that you have to operate that patient in order to prevent the complications of the Staghorn calculus. That is the severe urinary tract infection, that is the complicated UTI, or recurrent urinary tract infections, or the renal damage which it causes. However, the surgery may not be possible in all the cases. So there is one this one TV series is there, that is Money Heist, in which it has been said by the professor that sometimes truth is the most important part of a walk.
Nitu, I would like to interrupt. Can you please optimize your screen, or please make it a full screen presentation? You have not made it a full screen presentation.
Okay, sir.
Let me tell you what to do, Dr. Neetu.
Yes,
go
sir.
to share screen again. Then go to the first slide, the slide presentation. So don't remove it. Go to the share screen.
Yes.
And first slide, yeah. No, we are not seeing your screen now.
Sir, now
on the bottom you have the enlargement screen. You have a right side bottom 69% before. One icon is there below 69% before. You click that. Yeah. On the bottom you have
near 53% you have a glass shaped icon is there. See, here the zoom out and zoom in column.
Below.
On your right hand below.
Or even press the F5.
First,
Even press the F5 button.
Go right hand below. Okay.
Right
okay.
hand below.
Yeah. Fine. Press it.
Or else you can continue.
Now we
no
can
problem.
see.
No.
Press the F5 button, it will be better.
Nothing is happening.
Press
problem.
A5. Okay, I think we should move on, sir.
Dr. Harsha, are you right?
Lot of time.
Okay. Proceed with the same.
Okay, sir.
Proceed with the same. Don't waste time. Share
Yes.
the screen. Proceed. No problem. Don't worry.
Sir, should I start?
Yeah, please carry on.
So there's a famous TV series in which
Yeah, now it's okay.
so there's a
carry on.
famous yes. So there's a famous TV series in which the professor has told, that is the money heist, in which he has told that sometimes the truth is the most important part of a war. Means you're not supposed to fight each and every war, especially when you know that you're not going to win it. So like you should know when not to operate a patient. So this is a case report which was presented in 2015, in which they took a female patient who was having bilateral Staghorn calculus. They had operated on one side, and because of some reasons they could not operate on the other side, and the patient came after 9 months. For those 9 months she was on and off on antibiotics, and when after 9 months they repeated a CT, they could see that there was a complete disappearance of the stone. Just with the medical management by giving a long-term antibiotic. So this paper actually tells that definitely there is a room for conservative therapy. So then again, one more paper is there in which they had presented a summary of the papers in which they had compared the outcome of the patient, those who had undergone conservative therapy for Staghorn calculus. So in 1982, the Bouchard paper, they showed that in none of the patient had any renal damage, none of them needed dialysis, none of them had any urinary tract infection. And also in the paper presented by Douche in 2016, the percentage of progressive renal damage was 13.6%, and the dialysis was needed in 9.1% of patients. So again, this paper shows that there is a room for conservative treatment where you cannot go for a surgery. Now the question arises, where can we consider conservative approach? So the very few indications are there. First, if the patient has associated comorbidities where you cannot operate the patient, he is unfit for surgery. And second is when the patient does not want any surgery. So when we are considering surgery also, we should always see whether the patient is symptomatic or asymptomatic or unilateral or a bilateral Staghorn calculus, because the results of conservative therapy are better when the patient is asymptomatic and unilateral, because the previous studies also have showed that the morbidity and the mortality and the progressive renal damage is much higher when there is a bilateral Staghorn calculus. But one thing we should note, that the conservative approach does not mean that you have to just observe. You can go for a medical management, and it is an acceptable treatment in well-selected non-surgical Staghorn calculus patient. So when we we say that we have to give conservative therapy, we actually mean is that we have to go for a metabolic evaluation, find what is the metabolic abnormality in these patients, and we can go for a directed therapy along with the dietary advice. Now, why metabolic evaluation is needed? We know that in Staghorn calculus, they can be of 3 types. They can be either a mixed stones, metabolic stones, or pure steroid stones. Mixed stones are the most common, which may be a combination of infection plus metabolic stones. Metabolic stones can have like calcium oxalate or cysteine or uric acid. Pure steroid stones are the percentage are very less in for pure steroid stones. So the metabolic evaluation becomes an important part. So this is a chart which is taken from Campbell, which is showing what are the recommendations for the metabolic evaluation. So obviously the history becomes important. The blood screening of the patient becomes important, which should include the RFTs of the patient, the calcium and the PTH hormone, the urine analysis for the pH for pH, then the urine culture to see if any urea splitting organisms are there, radiography, and the stone analysis if it is available. And along with this abbreviated testing, this patient should also go for a proper metabolic testing, which should include 1 or 2 24-hour urinary collections. And they should be analyzed for total volume, the pH, calcium, oxalate, uric acid, citrate, sodium, potassium, and creatinine. And once you identify what is the metabolic abnormality, we can start the treatment, and then again we can repeat the metabolic testing after 3-4 months to see if the patient is responding to the treatment which we have started. So in the dietary advice, as we all know, that the adequate water intake should be there of 3 to 3.5 liter. The sodium, there should be a low sodium diet, that is 5 grams per day of sodium, salt. Then they should be started on DASH diet. This DASH diet is rich in fruits and vegetables. It is moderate in low fat dairy products and low in animal protein. Also, the calcium intake should be moderate, 1 to 1.5 gram per day. They should be started on citrus juices, and food which contains high oxalate, that is chocolate, nuts, and all, should be avoided in these patients. Then for medical management, as we all know, like for if this hypercalciuria you have identified, then thiazide diuretics becomes the important part of the management, which includes hydrochlorothiazide and chlorthalidone. Sodium cellulose phosphate and orthophosphate also we can use, but when we are using orthophosphate, we should know that patient should not be having a urinary tract infection. We should not use orthophosphate. Infection stone, we can go for acetohydroxamic acid, because when you use acetohydroxamic acid, this will actually stop the growth of the infection stone, because this is a urease inhibitor. So if there is a patient who is having a stone, who is having recurrent UTI, you can think of starting acetohydroxamic acid, that is 250 milligram TDS, but you have to know that it is contraindicated if the creatinine is more than 2.5. And according to if there is hypositrate urea, which is the most common abnormality that is found, you can start the patient on potassium citrate. If there is hyperuricosauria, in cases of hyperuricosauria, when they form calcium oxalate stone or the uric acid stone, the most important abnormality is that they have low pH. So you should always start this patient on potassium citrate. And to decrease the concentration of uric acid, we can give allopurinol or febuxostin. Cystinuria is not very common. But the treatment will be thiola or D-penicillamine or captopril for this patient. For hyperoxaluria, there are not much options available, but we can give vitamin B6 for them. And then we can also give oxalobacter formigens. For this, there are entry-coated capsule comes, which we can give for these patients. Along with that, we also should know that many of these patients, they are already suffering from hypertension or diabetes mellitus. So that should be controlled tightly. And the surveillance imaging should be done. Follow-up should be done with the RFTs and the urine analysis, urine culture, to know if the treatment which you have started is actually working or not. So based on the papers which I present, the example which I gave, the summary is conservative management of Staghorn calculi is not as unsafe as previously thought, and selection of patient with unilateral asymptomatic stones with minimal infection should be considered. Thank you.
Thank you, Dr. Needu. Thank you. Thank you all three presenters. There are a lot of questions, but we are running short of time. I'll take majority answer has been given by Dr. Abhijit. One question is there any role of anatrophic nephrolithotomy in case of huge burden of stone in CKD patient nowadays? Any presenter can give the answer.
I think anatrophic nephrotomy in this current era would not have much role, and I think the seniors from this among the audience can give the answer, I think, sir, because they must have seen, especially Pal sir would be in a better position to give this answer, sir.
It has been rightly put as a historical surgery. I don't think now there will be any role of this. There are better modalities available with minimal invasiveness. So it should be put as a historical surgery.
Okay. The next question is, if multiple punctures are made in patient with CKD, what is the explanation of for renal function remain stable, like same as pre-op?
So that, sir, for that I have answered this. There are multiple paper, including our institutional paper, where we have found that multiple tracks in multivariate analysis actually did not found as a predictor for poor outcome of PCNL in Staghorn's patients, sir. So it's quite safe, sir.
One last
Abhijit,
question is,
I just want to ask one question. Abhijit, you said that it is essential to place a PCN in all patients with CKD before operation. But in our experience, we have seen that it is very difficult sometimes to put a guide wire past the infundibulum, and it is a tightly fitting stone with no space. How do you encounter such situations where you cannot get the guide wire through the infundibulum into the pelvis? How you put a PCN?
So regarding, sir, a PCN is not must in every Staghorn patient. If you want to, so I presented that paper. If you want to take some decision, then you put a PCN, look for nadir creatinine, because you have removed the confounding factor of obstructive uropathy. And if we have to put a PCN, what we have found it as, you take a stone guided puncture, and if this is the stone, this is the pelvic analysis system, this is the pelvic analysis system. If you try to pass a glide wire, it will just skid off the pelvic analysis system. If you try to put it below the stone into this space, it's majority time goes into the pelvic analysis system. And that is how we put a Melicot, sir. But not every patient of Staghorn needs a PCN, sir.
Thank you, Dr. Abhijit. Thank you, all speakers, and thank you, conveners,
Thank you, sir,
for giving this opportunity. And now I hand over the mic to the Dr. Pal, please.
Thanks to the moderators as well as all the speakers. Thank you very much. And I am really thankful to Abhijit for stating there are different indications and there are very simple precautions which should be taken. CKD patients should be managed by PCNL. Regarding infection stone, golden hour, I would like to emphasize golden hour means you should see the patient within 6 hours of the PCNL. Go and see yourself. There is a quick SOFA score in which you see if the patient's BP is falling less than 100, if his tachypnea is more than 22, and if he is not as alert as he was before the procedure. Means these are the 3 parameters, and you put score to each one of these. If the quick SOFA score is 2 or more, it is patient who is going to, this is the patient who is going to fall into real sepsis, because less than 1% of the patients, they get sepsis, but 60 to 80% patients who slip into severe sepsis, they go for not only morbidity, but even mortality. So you have to be very specific. You have to worry about the sepsis part. Regarding bleeding, every track 0.6% to 1% of the kidney nephron loss takes place. More tracks, 7 tracks as somebody has put it, 7% of the kidney function is likely to deteriorate. Those nephrons are going to be scarred. So better to reduce the number of tracks. Lastly, the conservative management has to be really taken into consideration in some individuals. So we conclude the session 1 and let us move on to session 2. And I call upon the moderators of the session 2, Dr. Vilas Sable from Pune, Dr. Surya Prakash from Telangana, Dr. Prabhat Kumar from Patna, and Dr. Dilip Mishra from Agra to kindly take over and proceed with this session 2. Over to you, the moderators, please.
Thank you, sir. I hope all the moderators are there.
Yeah, you are audible.
Yeah. Dr. Vilas, you can start. You can introduce the first speaker.
Okay. Mr. Sumit Kumar. Pardon, sir.
Yeah.
Mr. Sumit Kumar from Sahibganj is going to talk on preoperative planning in a case of a Staghorn calculus. Over to Dr. Sumit.
Request for all the speakers, please stick on to the time. You're already running late.
Good evening, sir. At the outset, I would like to thank USI for giving me this opportunity. My topic is preoperative planning in a case of Staghorn calculus. Percutaneous nephrectomy is a standard modality of treatment for large and complex renal calculi, but there is fear of significant complications like hemorrhage and sepsis, and hence preoperative assessment and preparation is important. This involves primary care, pre-anesthesia checkup, possible involvement of other specialties, and shared decision making. Detailed medical and clinical examination is important. History of comorbidities like anemia, CKD, COPD should be taken. History of medications like anticoagulants and history of resistance is also important. Many urologists perform PCNL in prone position. Hence, high BMI may lead to difficulty in ventilating patients. There may be increased risk of pressure injury and nerve damage. There may be risk of injury to theater staff who have to prone the patient. Preoperative workup includes complete blood count and differential, blood group and spleen, blood sugar, serum creatinine, urine microscopy and culture, coagulation tests, ECG, X-ray chest, echocardiography. Patients on anticoagulant therapy must be monitored carefully pre and post-operatively. Anticoagulant therapy must be discontinued before PCNL. Despite cessation of antiplatelet agents, prolonged hematuria in tube drainage after PCNL has been reported. This slide has been taken from EAU guidelines, where drugs like warfarin, aspirin, clopidogrel need to be stopped before performing high-risk procedures like PCNL, especially the clopidogrel part, where the drug has to be discontinued 5 days before intervention and may be resumed within 24 to 72 hours with a loading dose. Urine microscopy and culture should be obtained before planned PCNL. Midstream urine is preferred. It should be collected 2 weeks prior to the planned procedure. It gives enough time to treat urinary tract infection. The Staghorn calculi are usually composed of magnesium ammonium phosphate, that's chloride, or calcium carbonate apatite, and these stones are referred to as infection stones. A multi-institutional review reported positive stone cultures in 72% of the patients with chloride stones. PCNL for Staghorn calculi is considered to be contaminated surgery. Large stone burden, prolonged operative time, positive stone culture, and need of multiple tracks make PCNL highly prone for infection and sepsis in post-procedure period. Urinary tract infection should be excluded or treated prior to PCNL. Perioperative antibiotic prophylaxis should be offered to all patients undergoing PCNL. Patients with infected stones, recent UTI, and positive urine culture, in these patients, prophylactic antibiotics should be given prior to PCNL and continue at least 4 days post-operatively. In patients with obstructive stones and urinary tract infection, collecting system needs urgent drainage with a stent or nephrostomy tube for several days before stone treatment is performed. Obtaining a negative pre-operative urine culture may not always be possible due to stone or urine tract colonization. Here, oral culture-specific antibiotic therapy is recommended for at least 1 week prior to the planned procedure, or intravenous antibiotic therapy for at least 24 hours prior to the planned procedure can be given. Recommended antimicrobial prophylaxis. The first choice being second or third generation cephalosporins or trimethoprim, sulfamethoxazole, aminopenicillins, or beta-lactamase inhibitors. Alternatively, ampicillin, sulbactam, or fluoroquinolones or first generation cephalosporins can be used. Coming to the imaging modality, ultrasound, it's safe, reproducible, and inexpensive. It identifies the stones in calyces, pelvic junction, vesico junction. It identifies upper urinary tract dilatation. It has a sensitivity of 45% and specificity of 88% for renal stones. But success is dependent on observer. Ultrasound with X-ray, KUB, has better sensitivity and specificity for diagnosing renal stones. Ancestry KUB is more accurate than IVU or ultrasound. Size, density, and location of renal calculi can be determined. Both ultrasound and CT can provide information about interposed organs during percutaneous access. CT urography with 3D coronal reconstruction of stone volume and pelvic calyceal anatomy helps to decide which calyx is to be punctured. It helps to stage or plan multiple punctures for PCNL for large complex renal stones. Thereby, it helps to achieve higher one-stage success rates. Nephrometric scoring systems help to predict success and complication rate of PCNL. Usually used are guide stone score, Crow's nomogram, and stone score. These are based on CT scan. Stone burden is calculated. In each of these nomograms, presence of Staghorn calculus has been given a higher score. Stone nephrolithometry scoring system, the variables included are stone size, tract length, obstruction, calyces, Horns per unit. It stratifies patients into low, moderate, or high risk groups, and it is clinically practical for decision making and surgical planning. Guidestone score, the limit, the in this the grade 3 has Staghorn partial Staghorn calculus is included in grade 3, and Staghorn calculus is included in grade 4. The limitations of GSS are it does not include stone size, calyceal involvement, density, and composition, and it is based on published literature and expert opinion. Coming to the Crow's nephrolithometry nomogram, the variables included are stone burden, stone location, prior treatment, presence of Staghorn, number of stones, case volume per year. This is a data-driven model and has been found to be superior predictability for stone-free status and post-operative complications. Coming to the functional imaging study, which like DTP or MAC3 should be performed if clinically significant loss of renal function in the involved kidney or kidneys is suspected. Lastly, patient counseling is also important. Patients should be explained about post-operative complications like need of blood transfusion, possibility of angioembolization, sepsis, or need of tube thoracostomy or injury to the bowel, and possibility of residual fragments and need of ancillary procedures like ESWL, RIS, stage, or relocational should be discussed with the patients. Thank you. Hello.
Suryaprakash, unmute yourself. Dr. Suryaprakash?
Yeah, sorry, sir. Thank you, Dr. Sumit, for the talk. I think we'll take the questions at the end of all the 4 talks. Now I'll invite Dr. Aditya Sharma to speak on is supine PCNL justified in a case of Staghorn calculus. Dr. Aditya Sharma is a consultant urologist from Lucknow. Is a good academician. He does a lot of supine PCNLs. And now I invite Dr. Aditya. Dr. Aditya?
Thank you so much. Good evening, everyone. I'll just share my screen. So I hope the screen is visible.
Yes. Go ahead.
Yeah, perfect. Thank you so much, Dr. Surya. Thanks for this opportunity. I find the question little suspicious. Is supine justified? So I think the question itself is suspicious about ability of supine PCNL. And being a proponent of supine for almost 7 years now, I can with confidence say absolutely yes. And I will just share why one should choose supine and what could be the apprehensions which one might have and which I will try to answer here. So why supine? Of course, we know all the advantages. They have been discussed over and over in various meetings. So someone can still say, okay, you saved some time, some money for the patient, you made patient little comfortable. But yes, there are situations one may not be able to do supine PCNL. But if the procedure is followed correctly, I'm trying to explain why supine should be your first choice. So what are we trying to achieve here? So basic confusion many people have, they are not sure actually what is supine position. So technically, I mean, keeping patient just supine is not possible. So supine position per se is a position where you avoid positioning patient multiple times. You give adequate exposure to the desired area. Airway remains accessible throughout the procedure for the anesthetist. Type of anesthesia, GA versus spinal, should be convenient to every surgeon as much as possible. And lower tract should be accessible throughout, and it should provide access to all the calyces. So these are our desired goals which we expect. But what are the apprehensions, or you can say limitations, one may think of? So position is first big confusion. Why should one choose one position, and does one has to modify his position depending upon the case? Second is puncture. Again, the concern is about where to start the puncture, how one should be able to reach. If somebody has to take multiple puncture, how it should be done, and will one be able to maneuver the nephroscope as they would do in other situations? And sometimes the system pressures because in supine remain low. Is it a hindrance, or how one can overcome it? So I'll just speak about the positioning. This is how the supine PCNL started in 1987, the original Valdivia position. So this is the position which was first time used 87, but for the obvious reasons, this was not popular because you can see the limitation of the access area, expected hindrance from the table and everything else. So till 2008, it went into shambles and nobody hardly talked about it. Till Galdakao modified this supine Valdivia position, or they called it a GMSV in the following position. We also utilize this is how I started my supine PCNL journey. This is 7 years back, patient under spinal anesthesia, comfortably awake, and this is the position actually. But to begin with, what limitations I felt, yes, sometimes when I'm moving my nephroscope here, it can come and hit the table. And of course, the superior calyceal access was very difficult. So we further, another position we tried was the Bart's flank free position. Yes, this is a good position. The flank is free. You get more space for maneuverability of your scope, but the area of the superior calyceal access remains largely inaccessible. So most of the surgeons who are being apprehensive about ability to do a Staghorn because they may need a superior calyceal puncture, they may need all calyceal access. So mostly they have explored these situations, and I have been through all these dilemmas. Further, we modified the situation. We wanted a position where it fulfills all the criteria which are needed for a supine position, and at the same time gives ample space and also accessibility to the superior calyx. So yes, it is a one-time position. You don't have to position again and again. It keeps the flank free, so you get more space for your scope. Airway remains accessible throughout. Spinal anesthesia can be conveniently given. Lower tract remains accessible throughout the procedure, and upper calyceal access is equally possible. How you position the patient, just 3 simple steps. Put the patient in lithotomy, how you normally put, turn the patient laterally to some degree, and lower the ipsilateral leg. Even the heaviest possible patient, there is a 150 kg guy, he is being positioned just by three person, surgeon, anesthetist, and one assistant. So you don't need too many assistants for this. I'll quickly come to the puncture part. So what are the concerns regarding the puncture? How should one go about supine PCNL and where to proceed? So you can see the C-arm remains, this is the standard 0 degree position of the C-arm, and C-arm is rotated craniocaudally like this. So the X-ray tube or the eye of the X-ray is here. This is from the X-ray rays are initiated. And as we see, this is the needle, this is the intensifier, this is the X-ray source. Once you are starting the puncture, if the puncture is either it can be below or above the kidney. So if it is below the desired calyx, then the needle will move up. When you turn the C-arm like this, the needle will move up. So it will be going opposite to the X-ray source. And if it is posterior, if it is anterior, it will move in the same direction as the X-ray source. So it will move down. So this is how the needle movement we track. I'll show a short animation regarding how it should be done. So you can see the needle here is below the calyx. And if you want to reposition, you can see once we rotate the C-arm in 30 degree, so needle is below and it is going in opposite direction to the X-ray source. So it is posterior. Now you can correct your direction of puncture and go forward and make a right puncture. So with these adjustments, the basics of the puncture are clear. Next, I'll go to how you plan a superior calyceal axis, because inferior and middle calyceal axis puncture can be done conveniently by this method. One is to follow the anatomy of the kidney. So anatomy of the kidney is such the lower calyx is more lateral and anterior. Middle calyx is in the mid part, and of course upper calyx is more posterior and medial. So this is the calyceal anatomy here. So the planning of the puncture has to go in the same direction. So if you're moving towards the superior calyx, your puncture keeps on going medial and medial. So that is why it is very, very important to have enough space. So here is the role of osmal position. It gives you a lot of space here to access the superior calyx. So this calyx you enter is in the same way as you would enter in your prone PCNL case. The steps of the puncture remains the same. We follow the same as principle. About the maneuverability, it is well proven that in supine position, nephroscope mobility is better because you are going easily from inferior to superior calyx as well as from superior to inferior. So in other positions, it may not be feasible all the time. Here, almost 80% of the time, you can go from inferior calyx to the superior calyx and clear most of the stool. If the system becomes collapsed, then again there is an option of you can block the outlet with the rubber cap, or you can use a Shaw's access sheath, Shaw's access sheath, and that can be used. Kaushik Shah, sir, he has demonstrated very well. Again, Staghorn can be done in like every situation, and this is the exclusive situation where one could not imagine of doing a prone position because it had already failed once. He is a patient of osteogenesis imperfecta with a Staghorn calculus. His limb positions are very unique. I mean, it is hardly possible to move him in one way or the other. He's just tilted in lateral position. We made enough space in the back to access the system. We cleared. The puncture went like, as I already described, the puncture is done. Most of the stone is cleared from this calyx access, and we used flexible ureteroscope access or the ECRS from below to clear the residual part which was there in the superior calyx. So this is another extension because next talk is about ECRS, so I'm not elaborating on that part. So the supine position goes beyond Staghorn. This stone is beyond Staghorn. There is stone more than the volume of the kidney itself, and even such stone can we have cleared in 2 sittings. There is no need to be heroic or be a Superman trying to clear everything. You see here are 3 punctures are done. So what I had done, I had planned my punctures. I anticipated I may not be able to clear everything from 1 puncture or 2 punctures. So I planned my punctures, and then the beginning only I had all the 3 punctures. So what happens when the supine position, when the system becomes collapsed, it becomes difficult to distend the system with the contrast. Superior calyceal you can still visualize because the superior calyceal more below the level of inferior calyx. So by gravity, the contrast goes and condenses in the superior calyx. So if you have not taken superior calyceal access in the beginning, you can still plan it. But yes, if you are planning a middle calyceal puncture or you are planning an inferior calyceal puncture afterwards, it will be prudent to take a puncture in the beginning itself and you plan it. So to summarize, of course, the supine PCNL will have its learning curve. Best ways to go forward, and if you want to do Staghorn stones by doing supine, one has to learn the procedure in a right way and right method. Increased mobility of the kidney can be avoided by balloon dilatation or single step dilatation. Apprehension of visceral injury or primarily the colonic injury is not very much founded in the studies, and one should not really worry about it, except the position where retrorenal colon is there. I mean, that even in the prone position also it can get injured. Occasionally, longer access track can happen. So one needs to plan the shortest track possible in a obese patient. So don't try to make your track very long, especially in the obese patient. Multiple puncture, anticipate the puncture, and or in cases where you need, use ECRS. And of course, superimposition of the spine, you can rotate C-arm 5 degrees away from you. and that can be avoided. And thank you so much.
Thank you, Dr. Aditya. As I said earlier, we'll take questions at the end of the talk. There are some questions in the chat box. Now, Dr. Prabhat is there. Dr. Prabhat?
Yes.
Dr. Prabhat, can you introduce Dr. Chandramohan, the third speaker?
Yes, Dr. Chandramohan is from Hyderabad. He is a well-known figure in RIRS and HOLEP. He is going to present his talk regarding role of ECIRS in management of Staghorn calculus.
Yeah.
Now over to Dr. Chandramohan.
Am I audible?
Yes, Chandramohan. Your slides are seen well.
Thank you. And I thank USI Council for giving this opportunity and Dr. S.K. Paul sir for giving this opportunity. My talk is role of ECIRS, endoscopic combined intrarenal surgery in Staghorn calculus. As you all know, it has gained recent popularity owing to renewed interest in supine PCNL and widespread acceptance of RIRS. ECIRS promises to be a single-shot effective treatment for complex stones. It can provide better SFR is the one which I am going to talk. There are a lot of challenges as previous speakers have spoken: anesthesia, position, multiple tracks, operative time, complications, staged procedures, auxiliary procedures. Last two are important. Even questions have been asked, can we stage the procedure? So how to come out of these things? Generally, we say that can we get two? If we can get easily without an additional dilatation and puncture, we'll be happy. So anesthesiological advantages, there's a lot of controversy, but whatever said and done, you have to accept that the anesthetist will be very comfortable in supine position for cardiovascular and pulmonary management, less injury to peripheral nervous system, less risk of tracheal compression, less risk of ocular damage and thromboembolism, vena cava compression. In obese patients also it is safe. Some of the points I am mentioning will be overlapping about the supine PCNL, but in obese patient, especially with breathlessness, emphysematous pyelonephritis, CRF patients, many of us have seen that we do ultrasound guided PCNL in supine position. The position in ECIRS position is half minute. Generally, I say that if you keep everything, it takes half minute. Simple lithotomy and turn the patient and two bolsters hardly takes less than 1 minute and less manpower is required. Now coming to the tracks, this is the main advantage of ECIRS. Number of tracks can be reduced. There are less articles because in the 2008 onwards, Caesar Marco-Scaffon has made this subject interesting. After that, Gudo Gusti sir is also making this subject interesting. Only two in the world are making from 2008 articles appear again pro for supine PCNL and ECIRS. So decreased need of multiple punctures, operative time is longer but shorter than traditional PCNL, less need of ancillary procedures. This article is a well-quoted article from Turkey Journal of Urology in 2020. Most of the quotations are from this article. Again, the NRCT study ECIRS versus mini PCNL from the Urolithiasis journal. This is from the Jun Lee. This is a comparison of ECIRS versus normal prone PCNL. Operative time is less, hemoglobin drop is less, post-operative hospitalization days are less. These are the significant, some of them are significant. And the other parameters are single session SFR. Definitely in whatever the articles that are published, it is a p-value significant. And especially medium and high volume stones, the chances of clearance will be much more because you can use RIRS. Complication rates are also comparatively less, even though it is not statistically significant. An important information, strain stress is very less because you will have an access sheet, you will have the flexible scope from below. Again, from Staghorn, very good systematic review involving 14 studies state that SFR is more than 80%, ranging from 61 to 97%. Complication rates are 5.8 to 44%. Bleeding risk is low, 0.8 to 2.1. As S.K. Paul sir is mentioned, the glomerular number of nephrons damaged as well as bleeding is more with 7-8 tracks. This can be clearly avoided with the ECIRS. Sepsis very variable, ranging from 3 to 40%. The decreased need of multiple accesses, it's only 1.6 to 10%, whereas it goes above 20% in prone PCNL. Shorter operative time and traditional PCNL, less need for ancillary procedures. And another paper, which again from the Staghorn in Endourology, European Association of Urology paper, says that usually in Staghorn calculi, it is 70 minutes average time, 81% first and second procedures, 87%, hospital stays average 5 days. So sepsis, it says that in supine PCNL, whereas as well as combined with RIRS, the drainage of the water either from the access sheath or from the ampulla sheath will help the pressure to be lower side. As you all know that the speaker who has spoken on infections, the infection is inside the stone. So when you are breaking it, the chances of, if the pressure is more, the chances of septicemia will be more. So all benefits of supine PCNL like anesthesia, less radiation, benefits of FIRS, better stone washout will be there with ECIRS. See, you see the video which I am recording out of academic interest. We use a flexible scope in Staghorn calculi inside the calycial system. If you are fortunate to see the calycial system, see I have punctured, and now one more puncture is coming from the proper position like this, and then go ahead. The chances of bleeding are very less. All the 3 pictures show that in the center of the calyx it is coming. Radiation exposure is less. This is again from Staghorn from World Journal of Urology. Definitely, if you understand the system, you'll be much away in supine PCNL. And because of the flexible scope also, the radiation is less used. Retrieval of guide wire through and through access ureteroscopy is always helpful. A better stone fragment washout, needless to mention, the stone fragments, once you break, less need of forceps is required. They will be coming out. Ergonomic advantage is that in supine PCNL, you can sit and do. Staghorn calculus, there is always a component of body pains at the end of 2 hours. Prone PCNL, which will not be there in supine PCNL, you can comfortably sit. I agree with that. And ECIRS versus PNL, again, Asian Journal of Urology is the article from Oliver Traxler, sir, and it is from 88% versus 59%. Operative time 84 minutes to 105 minutes, on an average 20 minutes more in prone PCNL. So again, the paper from China, from Bohan Wang, they say that one-step SFR is 58% and final SFR is 91%, which is especially first time when you do PCNL with supine and ECIRS, its p-value is significant. Now, disadvantage definitely yes, 2 monitors, 2 surgeons, 2 set of equipments. To be honest, one of my theater is small, old operation theater is very small. In this video, you can clearly show, clearly see, even though space for movement is less, but you can have these 2 monitors. I'm sharing 2-3 short videos here, how it will help. See, this is a case, it looks very simple. Any prone PCNL surgeon says that in one go, I will remove it, even after seeing the CT also. But this is a position of the this thing. RGP, once you see the RGPC, most of us not doing the IVP, we miss this type of bifid system. Even this also can be cleared by 2 punctures, but that is not the only way. See, I have done inferior calycial puncture, but middle part of the inferior calyx stone needed one more puncture. So like this, after doing, clearly the stones have come out, but the only problem is upper calyx, we cannot go. See, upper infundibulum is narrow, and from the lower tract, we are not able to go. Even in supine PCNL, this can happen from the lower calyx to the upper calyx. What will you do? You put a flexible scope, bring the fragments, and you need not do powder. With the advent of the high wattage lasers, if you keep 2 watts and 10 joules, make a designer cut, make 2-3 pieces like pneumatic lithotripsy like this, fast, and then get away. Even one stone was by the side of the ampulla after doing second dilatation. So flexible ureteroscopy definitely is useful in such conditions. In fact, it can show all the calyces at the end. Then see, this is the, by the side of the ampullage, it's sometimes very difficult to take out the stone. This is the second case is for right complete Staghorn. This is also very easy case. It appears for lower pole you can remove, but sometimes see, if you see the picture, 1 or 2 stones will be away, not connected with the pelvis very clearly. See here, one dilatation is done, the scope could not go, and the other dilatation is done, that could clear only half of the stone, and ampullage sheath behind, one more stone was there like this, and flexible scope, very useful by the side of the ampullage sheath. 2 important points we have to mention is flexible scope going to the by the side of the ampullage sheath is easy if you withdraw the ampullage sheath just up to the periphery of the calyx and switch off the light from the nephroscope point. If you see a short 10 seconds video here, how the flexible scope person with a disposable scope with beautiful vision after 2 punctures also and getting the stone into the mouth of the nephrostomy person. These stones will definitely decrease the, see the picture how the calyx has collapsed by the side of the ampullage sheath. So sometimes middle calyx has perfect anterior posterior calyx, you may miss the stone. So for left partial Staghorn calculus like this, it is again appears easy. If you see here, I was planning 1 puncture and remove the stone. Initially, I struggled. After that, I have to do a parallel calyx 1 more puncture. Most of the times, if the dilated system is present, we can get away. But if not, then we have to go like this. Now coming to the very important case, it's not Staghorn. 13 stones were present in a partial PUJ, but DTPS scan, no obstruction. You see how trifid system is present. In this type of Staghorn, lower calyceal puncture we have done, and we tried to take out the stones. After removing the 4 stones, many stones are there inside. See, if you see here how it helps, the 30 French tract dilatation is done. And we cannot go into the upper and middle part of the partial trifid system. In that case, you go with flexible scope, take out 1 stone and give. In matter of 5 minutes, all 13 stones were delivered from the upper calyx and middle calyx to the lower part. The ultimate idea is that lower calyx, majority of the people are comfortable avoiding the tract through the pleura or the liver. So this can be avoided by lower tract, lower calyx puncture. See all these stones, 1 stone. This is partial PUJ. Post-operatively, patient did not require any pyeloplasty. That is a different subject. Here, all the secondary stones are given to the ampullage sheath. Now coming to the last case, true loan, whenever there is a non-dilated system, multiple branches, partial Staghorn, this is actually, even though pelvis doesn't have stone, this is actually true Staghorn type where you show the deer with the Staghorn. In these cases, see, I have done lower calyceal puncture. I have removed as much as possible. After that, how many calyces will puncture? Nearly 3 to 4 calyces were there which occupied with the stones. In such case, the best is you go with flexible scope. All the calyces you can inspect. Now you can see small strunes will be there. They are not large volume. Each calyx you can go make fragments and get them to the ampullage sheath. That way you will clear the stone. So to conclude, the increased single step SFR is the main advantage of EC-IRS, allows visual inspection of all calyces at the end, decreases number of tracks, operative time, need for ancillary procedures. It may not be applicable in all the cases, but in selected cases, especially trifid system, especially multiple stones in a narrow infundibule, RIRS plays a major role in SFR, better SFR. Thank you very much for giving the opportunity.
Thank you, Dr. Chandramohan. We will take question in the last. Now moving to next presentation. Next presenter is Dr. Tanuj Paul Bhatia. He is from Faridabad. He is head and senior consultant at Institute of Laser Urological Surgery, Sarvodaya Hospital. He is again known for his RIRS and HOLEP work. He has many presentations and publications to his credit. He has organized many workshops, including laser cone in 2017 and 22. He also demonstrated many live surgeries in different workshops and conferences like Flexi URS course, Kathmandu, and East Zone UCCon Ranchi, and HOLEP versus THULEP held at Hyderabad in 2022. Now, over to Dr. Tanuj Palbhatia. He is going to speak about role of RIRS in management of residual fragments.
Is Dr. Dilip there? Dr. Dilip Mishra? Dr. Dilip?
I think he's not there, sir.
Okay, then Dr. Tanuj, you carry on, start.
Thank you, sir. Thank you, Dr. Brawat. Thank you, Urolithiasis subsection of USI for this opportunity. As mentioned, I will be talking about role of RIRS in management of residual calculi. So we know that even after all forms of PCNL, be it supine, prone, ECIRS, there is still significant residual stone rate. And after a routine PCNL for Staghorn stone, this can be, it can have a clearance of 75 to 90%. That means about 10 to 25% of cases will have residual stones. So urologist should attempt for complete clearance, especially for Staghorn stones. And the different salvage options in such situation are ESWL, redo PCNL, RIRS, and lap or open surgeries. So this beautiful paper from Nadia group, it has a very large number of Staghorn stones, and they have looked at the location of residual fragments and its clearance and the different modalities that have been used to treat it. So if you look at this particular chart, we can see that most of the residual stones after a PCNL are actually lower calyceal stones. However, most of these, the big majority of these can actually pass spontaneously. And after that, many of them will require Flexi URS, and similar for the rest of the positions in the kidney. And if you look at the size, then most are smaller stones, they would pass out spontaneously. As the size increases, then they would go ahead and require a RIRS or a PCNL. So why RIRS is very good as a salvage procedure? It is the flexibility of the flexible URS which allows us to reach different locations in PCS, making it very suitable as a salvage procedure. Even diverticula and stenosed infundibula can be identified, they can be widened, and the stones can be treated. Identification of intraparenchymal calculi may also be possible sometimes, and some might be amenable to treatment with laser. Also, it prevents another puncture in the kidney. So I'll be sharing a few cases now. I am not sharing routine simple cases. These are little tricky cases. That's why I'm sharing here. This is a post-lap assisted PCNL ectopic kidney case. Patient 45-year-old. We can see the scars of the lap assisted PCNL here. And he had 3 residual calculi, 1 in the pelvis and 2 in the lower pole region. That is the RGP at the time of RIRS. This is a 6-year-old video, so please don't mind the quality. It is of 2016. So we go ahead with the flexible URS. We go enter the kidney. After we enter, we inspect all the calyces. We find some papillary calcifications in different calyces also, which means this patient is very much prone for stone formation. And then in the lower pool, we find 2 large stones. So what we did, we used a basket and we caught these stones. It was a nicely dilated system with a wide infundibulum. So we transferred these stones to the upper calyx, which is always the preferred position to fragment the stones compared to a lower calyx. And then we treated these stones initially by dusting. Gradually, as they became smaller, we did the popcorning. And then after we had finished treating these 2 stones, there was a shadow in the upper calyceal region, which was not being seen through the endoscope. So then we saw this little grayish area covered by mucosa, which was at the site of that stone on fluoroscopy. So we gave a very superficial incision with the laser. The trick here is not to dig into the mucosa. It should be a little away from mucosa so that you are incising as well as coagulating at the same time. And as we could see the stone, gradually we started incising just over the place where we could see the stone. There you can see the laser, and you can see we are incising just over the stone. Very fine movements are required in such cases, not to be done by beginners. And gradually we entered that cavity. As we entered the cavity, we flushed water, the cavity also widens. Then we fragmented the stone further inside that place only, gradually flushing out the fragments from that cavity. So this was actually an intraparenchymal stone which would have gone inside while manipulation during the lab-assisted PCNL, which was done earlier for this patient. And that's how we could treat this particular stone in this position. That's towards the end of the procedure. We can see very few tiny small fragments there. So we could do a complete fragmentation in this case. This is a post-pyelolithotomy residual calculi. There were two stones, one in the pelvis and another one in the calyx. The pelvic stone we could reach easily, so we just fragmented it quickly. And then we moved on to the calycial stone. And it was a small stone, so we basketed it out. So again, here also RIRS acted as a very good salvage procedure. Of course, one has to be careful while using basket. This is also older video. Now I would prefer to break the stone into two pieces and take it out. Now, many times there are stones which are in the diverticular, which are difficult to reach through the tracks which have been made in PCNL. If you have to make a track, we have to make a separate track for these diverticular stones. So they are very easily amenable through RIRS. Most of the times we would see a thin layer of mucosa over the stone and we can just fire over that just in the way I described earlier. And we can treat these stones. If it is still not seen, one can use a blue dye test, which has been spoken of many times, and identify the opening of the diverticulum, widen it, and treat the stone. On the left side of the skin is a lower pole diverticulum, and right side is an upper pole diverticulum. Both can be reached comfortably with a flexible ureteroscope. Now, this is a case of a small yet functioning kidney. This was a recently operated case. Patient had a pelvic and a lower pole stone. In first stage, we could do RIRS for the pelvic stone, and we thought maybe we'll be able to do RIRS, but we could not do RIRS in that setting, and even PCNL we could not reach because the lower pole, it was a small kidney and it was very difficult to reach this particular stone. So at the time of stent removal, we told the patient we'll make another attempt at RIRS, and we could just barely see the stone and we could not reach it. So what we did in this case was we inverted the scope. If you can see the scope in my hand, it's actually inverse, just like we do inverse morcellation in HOLEP. In this case, I inverted the scope so that my fiber comes out at 2 or 3 o'clock position. Of course, if you have two different types of scope, you can use that to advantage. But I found this particularly advantageous because generally we don't use the upward deflection of a flexible ureteroscope. So in such case, we would like to use a scope which is about to go, which already has some damaged fibers. But I took advantage of the upward deflection by inverting the scope, and I could reach the stone. Initially, we dusted the stone to reduce the bulk. Then we attempted basketing. We could not take it out, but we could bring it in a comfortable position to fragment it further. So after that, the fragmentation was done. In that position itself, you can see it's a little difficult manipulation of the scope. So now popcorning is being done to make the stone smaller and smaller. And there you can see complete fragmentation as evident on flexible ureteroscopy. Of course, it's a small kidney with a bifid system. We did a RGP to rule out extravasation. That's the immediate post-op X-ray. This is a picture shared by Dr. Rahul Yadav. Again, a post-PCNL extensive infundibular scarring. He could make incision over these different stones in different places, and he could break and treat them. So my take-home messages would be that RIRS is a useful adjunct as a salvage procedure. Flexibility assists in reaching difficult locations, not just the flexibility of scope, also flexibility of the surgeon. One has to be versatile. One should know different techniques which can help in treating the patients. One should aim for complete clearance, but primum non nocere. We should not cause more harm than the benefit we can give to the patient, and small egos make bigger surgeons. Thank you.
Thank you, Dr. Tanuj, for your nice presentation. Now we are ready to take questions. There is one question. Can RIRS be done without pre-op DJ stenting? From Dr. Sahnawaz.
Sir, okay. Sorry. Tanuj sir, please.
No, sir, please. You are. How can I speak?
No, sir. Actually, it's a part of ECRS. Sorry for that. The thing is, if the ureter is not dilated, you cannot pass access sheath. You cannot do RIRS. You cannot do ECRS. There is no discussion. You should be fortunate enough on that day that the ureter should be accommodable for access sheath so that you can put it and manipulate. If it is not there, put stent and do later on. There is not much discussion on that.
Sir, in ECRS, you can do threaded. You can thread it over the guide wire which you have pulled it through. The scope can be threaded sometime, yeah.
But manipulation will be difficult. Water will not come out. As such, post-PCNL dilatation doing RIRS is tricky. There will be blood and you will not have great vision. So we strongly recommend that if ureter is if ureter is tight, better to stent and do these residual stones later on.
There is one question. In ECIRS, it's supine PCNL with.
As aptly said by Tanuj, not only your flexible scope, surgeon also should be flexible enough to change the decision.
Yes,
yes, Dr. Prabhat.
In ECIRS, it's supine PCNL with RIRS or supine PCNL with flexible URS or both. What's your?
No, I'm not understanding your question. It is same. RIRS means flexible ureteroscopy only. Question is flexible ureteroscope from below will make it ECIRS. Supine PCNL plus flexible ureteroscopy from below becomes ECIRS.
So whether it's primarily supine PCNL or primarily RIRS?
Yes. Which is primary procedure, RIRS or PCNL?
In Staghorn, we are talking Symposium and Staghorn today. So primary procedure is supine PCNL. Position should be in such a way that you should have access to most of the calyces in supine PCNL. After that only RIRS for small residual or peripheral calyceal stones. Primary supine PCNL, of course.
In endoscopic combined, the word combined stands for both simultaneous upper track and lower track access. So
there's a question to Dr. Sumit. What percentage of cultures are negative even in the presence of infection? Dr. Sumit?
White stones have been found with positive 22% of the cultures.
Okay.
So
Sumit, I have a question to you. You mentioned NCCT, CT urogram, DTPA. Suppose a patient with Staghorn comes to you. Which one you do? You do only a NCCT or you do a CT urogram straight away? And when do you do a adrenogram?
Sir, I usually do a CT urogram, sir.
You do a CT urogram.
Okay.
And when do you advise a nuclear scan? And which nuclear scan?
Sir, usually I don't advise this, but if you advise the we do DTPA scan if required. Usually it is not done.
Okay, when you're
Guru Prakash, I have a question. One person raised that in prone PCNL also ECRS can be done. Does anybody have experience in prone PCNL ECRS? I feel it is very difficult. I have tried. Split leg position is suggested by Michael Grasso way back, but after that, no articles on that because legs cannot be apart with normal tables. It is very difficult to go in between the legs in prone position. Anybody comment on that? Prone PCNL ECRS.
Chandramohan, I think Dr. Manoj Munga does regularly. He has shown even puncturing using flexible ureteroscope guided prone puncture.
Okay.
As you said,
Chandramohan, I have met surgeons who have placed the this flexible sheath before and then turned the patient prone.
Yes,
so
sir.
it is only that orientation has to be in a different way. Otherwise, it can very well be done in prone position.
Great.
So in males as well as in females.
Yeah.
So it doesn't make a difference. Actually, we are going into the integrity of the techniques and all. Let us remain confined to the symposium on Staghorn stones. And if you permit, can we start the third session?
Yes, sir.
Because most of the questions have been answered.
Yes. All the questions are answered in the chat box. So we can see the
We can
questions.
move
Then.
to next, sir.
So thank you very much to all the moderators and speakers. You have really done justice to the talks very well and covered the topic very well, the techniques and how to go about PCNL in a Staghorn. Now coming to the complications, and let us discuss this in the last session, session 3. And moderators along with me will be Professor Samir Trivedi, Dr. Ravi Kumar, and Dr. Nilanjan Mitra. So we are going to discuss the complication part of it. And I invite Professor Samir Trivedi to kindly introduce the first speaker, Dr. Harshvardhan.
Thank you, sir. And it's a very nice session that's going on, and it's my pleasure to invite the next speaker, Dr. Harshvardhan Tanwar. He is currently the director and consultant urologist at Lotus Super Specialty Hospital in Ahmednagar, Maharashtra. He has been the convener of Urolithiasis section of USI in 2022. He has given various guest lectures and demonstrations at various live workshops. He has over 25 international publications to his name. So somebody who is really good at what he does, and it would be a pleasure to hear Dr. Harshvardhan. Dr. Harshvardhan, please, you can start your presentation.
Thank you very much, Dr. Mee sir and Dr. Pal sir. We'd like to thank Dr. Sabni sir and Keshav sir for showing the responsibility of convener of this, the larger section of the urolithiasis. With this, I would like to start my talk. Today's talk is on prevention and management of vascular complications in doing Staghorn test. Am I audible?
Yes, very well. Please carry on.
So, in any PCNL, the biggest fear a young surgeon has, or even a master surgeon has in PCNL, is of the bleeding. So today, let's talk and let's get out of this fear, how to prevent bleeding during PCNL, and also the management of if it bleeds, how to manage. So let's wash out this fear from our heart and begin the talk. So beyond books, there is always a guru. Without guru, you stand nowhere. I would, especially in my life, I have 3 gurus in urology, Dr. Pal sir, Dr. Sabni sir, and Dr. Chandramohan sir, who has always guided me and taught me the best what we can do for a patient. Also, special thanks to Dr. Pankaj Maheshwari sir and Nitesh Jain sir in formulating this talk. There they are detailed. Unless and until the fear is washed out, you won't progress. You will always fear of the appearance of the stone in Staghorn, because in Staghorn you need multiple punctures. And doing a proper puncture is what we are going to see, how to puncture in a proper way to avoid bleeding. In such cases, in Staghorn stone, you always need multiple punctures near the stone. So a neurosurgeon has to do multiple punctures without risking the patient for bleeding. This is the case where we have done multiple punctures. How easily we have removed all the ampulla sheets, and every ampulla sheet was there of a 24 French fly. So incidence. If alone doing a PCN also, there is an incidence of 0.5 to 4%. In PCNL, the risk is increased as we dilate the tract for larger size, which is about 2% to 20%. If we do a CT scan, this is a very interesting slide. If we do a CT scan, in 90 to 100% of CT is done immediately after a PCNL, there is no significant or a very renal hematoma. So when we do PCNLs in a proper way, we are not going to injure the major blood vessel. So why a PCNL bleeds? First and foremost is, I always say that initial puncture is the best puncture. So a wrong initial puncture will land up in a very complicated case of a PCNL. Wrong method of tract dilatation, excessive manipulation during PCNL, where as we were discussing, as Dr. Pal, the technique is there for saline flushes for the residual stones in a Staghorn stone comes handy in such cases, or a wrong use of energy sources, and there are many patient factors also which can be related for the post-PCNL bleeds. So there is a window of success. When you puncture, if you see the anatomy of the kidney for doing a good PCNL and a good surgeon, you have to have a 3D anatomy in your mind first about the renal vasculature. As the renal, from the sinus, there are branches of the anterior and posterior segmental arteries, and there are many branches ahead also. So unless and until you know the vascular anatomy of the kidney, you won't be a good surgeon of a good PCNL surgeon. only there is a small window from the tip of the catheter that you have to come in the kidney and see the renal collecting system. So in this diagram, it is clearly seen, if you take parallel tracks to the renal blood vessels, then only there won't be any bleeding or there won't be any injury to the major segmental blood vessels of a kidney.
Yes, sir.
So
Yes, sir.
in this, there is someone who is speaking.
Yeah.
In this
Yeah,
CT scan, this picture is taken from Dr. Parker's slide. In this, it is clearly shown that the tip of the calyx should be the site of the puncture. Otherwise, then you are going to traverse a lot of parenchyma and damage major blood vessels. And we have shown parallel blood vessels, major blood vessels running parallelly to your puncture. What is the perfect entry? It should be always from the tip of the calyx, from the posterior calyx, so that there won't be any manipulation done ahead to see the stone or to enter into the different calyx. So in this picture, the A side picture is from the perfect posterior calyxial entry without traversing the major renal parenchyma. And the second side, you see that if the anterior calyx is punctured, then you have to traverse a lot. Make a straight, short, well-aligned track to avoid tearing of the renal parenchyma. So again, the same thing. When we are always afraid of puncturing the superior calyx, but superior calyx is the one which will give you the most easy access to all other calyxes and will help you in clearing the major Staghorn stones in a single puncture. But we are always of fear to puncture superficially. And in that fear, we try to come from below the rib and take the oblique track towards the superior calyx, which is then again traversing major blood vessels. Instead of that, make a suprapuncture puncture, be from the lateral means calyx. Even though if there is some of the pleural effusion, you can manage it with an IC, but you will be avoiding major infundibular puncture and also major blood vessels. So what are the pre-op factors? The main pre-op factors in PCNL bleeds are low surgeon experience and longer operative time. Of course, there is a paper who has stated that you have to master PCNL and almost 100 cases should be done to master the PCNL. Absence of hydronephrosis, yes, compact meaty kidneys, they will tend to bleed a lot because of the thickness of the renal parenchyma. Issue of infections, raised BMI, in diabetes, CKD, or coronary artery disease, old age, due to atherosclerotic blood vessels, they tend not to collapse and they start bleeding due to atherosclerosis. Previous history, again, a previous history of partial nephrectomy or pyelodysodromy will have fibrosis there, and again, the risk of bleeding will increase. Solitary kidneys, anatomical variations, you have to do a proper preoperative imaging modalities in such cases so that you won't injure a major blood vessels in anatomical variations like in ectopic kidneys or hot kidneys. Stone complexity. Again, yes, in Staghorn stones, as we are talking today, we need multiple punctures to clear a Staghorn stone. It is the truth, yes. But when we are puncturing such kidneys, we have to take care that every puncture is a perfect puncture, and we should avoid the major blood vessels in such puncture. When the stone complexity increases, the manipulation from the nephroscope also increases, and this tends to cause more risk of bleeding. So initial puncture, what is the perfect puncture while doing a Staghorn stone? It should be from the cup of the calyx. We should avoid an infundibular puncture, avoid making wide track. It should be mostly infundibular. It should be the posterior calyx. It should give the access. Anterior calyxial punctures will coil your wire. It won't go into the pelvis, and again the opposite wall injury increases. Always get a clear aspirate. Try to get a clear aspirate. Avoid pelvic punctures. Avoid intercalyxial punctures. There is a paper from, there is many papers quoted, the role of tranexamic acid. Always try to give a bolus dose of tranexamic acid of 1 gram before induction so that the blood transfusion rate during they tend to be very low. I am using this method since long, since last 6 years I'm following the same. At the time of induction of anesthesia, I try to give 1 gram tranexamic acid to every patient. So how should be the initial puncture? The initial puncture.
So we are injecting sterile NS1 below just to demonstrate that we have got a good puncture.
Even though the puncture is very medial,
so our wire has coiled into the
it was very close
upper
to
pole
the spine.
calyx.
Even then, we were having a very clear. It should be the goal. It should be the end goal of the puncture. and then the wire should fall
So I will
into
like
the
to keep my
renal
wire
pelvis
here
and
while
walk down.
trying
Even
to.
though in stagnant stones, the wire can be placed into the ureter with gentle maneuvering of the initial puncture. There is always a space between the stone and the pelvis. About the Y tract, of course, in the picture shown below, it is the middle calyx should be the targeted calyx. But from the skin entry, if you target the lower or the superior calyx, then it is going to be a Y tract. There will be more manipulation. There will be more maneuvering of the kidney, which will tend to bleed. It should be a shortest into the parenchyma, which should be there, and a perfect posterior collision puncture should be there. So management of the bleeding at initial puncture. We draw the needle, take a new puncture, avoid contrast extravasation because if contrast extravasations are there, you won't be able to see anything. Again, you will land up into. Target other calyx if you are not comfortable taking a puncture into a desired calyx. Always there are many calyxes to which you can enter the system and target the stone. So target a different calyx. If suprapuncture puncture, try to enter from the superior border of the leg. This is a very important point because if you tend to target the lower border, there are intercostal vessels and which tend to bleed a lot and which it will come out of your exit sheet also. So tract dilatation, again an important step in PCNL where single step versus serial dilatations. So there was a paper there that always it is if we use serial alkane dilator, which is better in non-dilated systems to avoid torrential bleeds. Size of the amplas does matter because you have to respect the infundibular size also. If you are in a compact system, if you are forcing a big size amplus to small infundibulum, it is going to tear and it will lead to bleeding. Direction and force of dilatation is also important. Limit the dilation up to the calyx. What for color of vitamin fluid or adjust the amplus. We always use the bibit amplus sheet. So just adjusting some of the amplus sheet inside the renal system will stop the bleeding itself. So this is again a small video where there is a wrong technique. This should not be the technique of dilating the tract. You are forcing, you are not respecting the path of the glide wire. It should be a very straight path while dilatation. As I told you, we have to respect the infundibulum, we have to calculate the size of the infundibulum, and so have to plan your dilatation track. The method of dilatation is very important.
See, I
I'm
am
doing
dilating the
a
tracks of
sharp
the
sheet
Shah
amplification.
sheet. I'm
See
just
how
rotating
easily
the
I'm
Shah
just
sheet
sliding,
and it
pushing,
walks
and
into
rotating.
the system.
It
On the
should
screen,
be
please.
in line with
I'll
the
just place the Shah sheet here while
infundibulum
doing
and
the assembly
your
work.
initial puncture site also.
On the
You
surface
should not
liquids,
just force your amplas
you can see
inside, and it should be a clear routine.
clear
This will
egress of
avoid
the
major
urine
input into the
coming.
blood vessel. Management of bleeding during the tract dilatation. If it is a mild bleed, just adjust your amplas, go inside, wait for 5 minutes, the bleeding is going to stop. Just rotate your amplas so that the blood vessels will get tamponade. Injection of tranexamic acid, as I already told you. Use of some hemostatic agents are there. If it's a severe arterial bleed, it's not your day. Just come out, keep an nephrostomy and discharge your procedure. I think I will just come to this point. I've seen Dr. Pal's video where he has entered into the IV from his initial from the track what he dilated. It was a nightmare to see, but we need a heart like Dr. Pal sir to just handle this case. Management of bleeding during PCNL, just pack and wait. Bimanual compression is the method. Diathermic coagulation is there, or insert an endotracheate to the track and just inflate it for the tamponade. This is a picture showing bimanual compression where you compress the kidney from both the hands and wait for 5 to 10 minutes. Bleeding during nephrostomy or use of energy source, excessive torque, as I told you, mucosal injuries when you are using labors in mini PCNL can cause a rupture to the arteries, trauma to infundibulary angle, perforation of the opposite wall. If you are too hard on the kidney, poor quality of vision, lithobur. There is a nice story of Dr. Pankaj Maheshwari sir where the lithobur slipped and it went directly into the renal artery and there was a gush of blood all over the OT table, but he managed it very successfully. Laser injuries, as we have seen. So, immediate post-op bleeding, if it is a skin side bleeding with no hematuria, compression and stitches can help. Hematuria well with nephrostomy in situ, manipulation of the tube, hemostatic agents. I have come across a case scenario where my nephrostomy was hitting a blood vessel inside, and there was a profuse hematuria down in the Polish catheter. So I just manipulated my nephrostomy tube and the bleeding stopped. So you have to hydrate the patient, bladder irrigation should be there, and anaphylactic support should be there. Delayed bleeding, it is relatively uncommon, 1 to 1.8%. Most commonly, pseudoaneurysms are there, AV fistula, calypsovascular fistula, or mixed region. Starts around 1 week following the surgery and presents as an intermittent, continuous or sudden blood. You can just differentiate what you are dealing with. If it's an intermittent, it's a pseudoaneurysm. If it's a continuous, you are dealing with the AV fistula. Patient relates it to the sudden exertion of movement, dislodgement of the blood clot of a transected fasting thrombosed artery, often requires readmission, blood transfusion, and interventional measures such as digital subtraction angiography. Formulate SOPs. There should be SOPs ready in your department of urology for post-renal bleed, because this is a nightmare. When the patient comes to you bleeding post-renally, you are in a state of confusion. So the SOPs should be formulated. The management, yes, there is conservative management, hemodynamics, workout, antibiotics should be given. Evaluation of the patient should be done with proper imaging studies. Keep ready blood transfusions and selective artery embolization. Initial management, monitor the vital signs, plan the nephrectomy, external completion. A blood transfusion should be there. Hydration and IV method. It is an important point because rapid post dialysis and swelling of the kidney, the capsule, which may enhance the tract component, and further evaluation should be done with angiography or CMI. When to do angiography? Hemodynamically unstable, life-threatening bleeding, repeated clot evacuation, multiple blood transfusions, renal Doppler showing vascular lesion, or continued hemoglobin or hematocrit drop. So these are the points one should red flags should be raised when such points are there and the patient comes to such scenarios. How does the conservative management help? Does it really help? So standard indication for same-day angiography, there was a paper published by Joy Chakraborty in which he has told that there are only 5% negative angiography rate when there is a post-ischemic bleed. So 95% of the time they got some or the other lesions that had to be embolized, or a coiling had to be done in post-ischemic bleeds. So on the same day angiography or embolization can also be planned. So what are the angiographic findings in the post-ischemic bleed? Majority are pseudoaneurysm, AV fistula, isolated arterial injury, or there might be multiple findings. So how does AV fistula occur? It occurs when a paired set of arterial vein is injured and arterial blood enters directly into the vein. The weak vein wall cannot sustain the high arterial pressure and it then ruptures. Mostly this is a continuous bleed. Bleeding into the collecting system is most commonly noted, but it can be outside the kidney as well. So arterial pseudoaneurysms, when high pressure leads to the lacerated artery, is transmitted into a low resistance connective tissue. Bleeding is intermittent bleeding as artery is injured, clots of, and then intermittently ruptures, often clotting off again at variable injuries. So this is a nice image given by Dr. Pankaj Maheshwari sir. You can see there is a pseudoaneurysm there. And on the other video slide, you can see it's a successfully coiling is done of the pseudoaneurysm. So nowadays, as we are advancing with the vascular management of such lesions, we can successfully stop post-ischemic bleeds. What is the super selective glue embolization? In coiling or embolization, there is significant parenchymal damage. But when we do super selective glue embolization, there is significant parenchyma which is preserved. It's a hyperdense glue because of the lipoidal contrast added in the glue. So this is a video showing super selective glue embolization done in a case of pseudoaneurysm. So the bleeding has stopped successfully, and the glue contains of N-butyl acetate and lipoidal contrast. Percutaneous access also is a new therapy where you do color Doppler of the kidney, find out the lesion, put a coil from vascular side, and from the percutaneous side you can just inject the glue into the pseudoaneurysm, which helps to control the bleeding. So what are the what might happen to the patient post embolization? We have to hydrate the patient. The continuous bladder irrigation should be there. There should be bed rest. Always the patient should be on higher antibiotics, as there might be necrosis and renal ischemia. If it fails, consider the repeat angiography. Complications, there might be renal artery dissection, post-embolization syndrome of nausea, vomiting, weight pain in the lumbar region, coil migrations. You can have stones over such coils which are migrated in the renal pelvis or a contrast nerve. Unusual sources of bleeding, of course, you have to respect the intercostal vessels. Picture I have shown nicely intercostal vessels just side of your tract. So you have to target the superior border of the rib, not the inferior border. You can see here
Harsha, please
again.
conclude. Harsha,
Yes,
please,
sir.
we
Yes,
are
sir.
getting late.
Yes,
And
sir. Yes, sir. Last
please.
slide. Last slide. Sir. I've gone through 2 patients who were having PTSD, that is post-traumatic stress disorder, after watching gross image areas, what they had post-PCNL. So they had a fear of death and they were psychologically disturbed, for the need of psychiatrists can be helpful in such patients. So to conclude, you have to respect the thing, you have to have a proper knowledge of the blood vessels, you have to be thorough with your skills. I will just end my presentation with a nice video. I was doing a live PCNL at Marathon and I have avoided over dilatation in this case. I have remained inside. It was a very compact thing, and you can see a segmental artery is just in front of my track. If I would have over dilated this track, I would definitely have injured this artery. So thank you very much. Thank you, sir. Thank you all of you.
Thank you, Dr. Harsha. Although this is a most important talk of the symposium, because Staghorn and bleeding, and this is the main thing which most of us get worried. But since time is short, we will discuss at the end one question which is coming to my mind. And the question I can put now itself. Let others also, other moderators and speakers should also discuss about that. Whether the size of nephrostomy tube matter and does it stop the bleeding complication? Now let us move further, and I invite Dr. Nilanjan Mitra to kindly introduce Harpreet Singh and call him for his talk.
Good afternoon, everyone. How impeccably you do PCNL, there are always chances of complications. The most common complications are generally grade 1 and 2 according to the Clavian-Dildo classification system, grading system. But there are chances of grade 3, 4, and 5 complications. So to deal with this type of complications, which are non-vascular one, may I call upon Dr. Harpreet Singh, who is the head of the Department of Urology, Mercy Hospital, Jamshedpur. He was the first honorary secretary of East Zone chapter of USI. He was an ex-council member of USI from 2020 to 22. He's a member of Urological Subspecialty of USI, National Convener of Urolithiasis Subsection of USI. He's the Chairman Scientific Committee of East Zone USI from 2022 to 24. He has presented multiple papers in various national and international meetings and demonstrated live surgeries in many conferences and published numerous publications. So may I call upon Dr. Harpreet Singh to share his views regarding how to prevent the prevent non-vascular complications. Harpreet sir.
Am I audible?
Yes, sir. Now you are audible.
Okay. So thank you, Nilanjan. I thank Urological Society of India and Paul sir for giving me this opportunity. Good evening, chairpersons, ladies and gentlemen. And I think as I was seeing that seeing the attendance going down from 206 to 121, it's enough is a evidence that nobody wants to hear and discuss complications, because complications are frightening. Whatever little experience I have, complications is not generally happens in a complex cases. It generally happens in a case where it is simple, anatomy is simple, stone is simple, and surgeon is very confident or overconfident, you can say, that he can finish in 10 minutes. So this is what my observation about it. So a very extensive and comprehensive presentation by Harsha on vascular. So I will take on non-vascular complications. So bleeding already discussed. I left with infection, bowel injury, injury to lungs, and injury to other abdominal organs. So the CROWS, the largest study which has conducted more than 5,000 patients, they said 0.5% complications are there: fever, bleeding, collecting system perforation, blood transfusion, and hydrothorax. And the 30 days stone phase is 70%. So factors associated with an increased risk of complications include increasing patient age, female gender. I remember Paul sir remarking in his introduction about a female patient, more operative time, comorbidity, and stone more than 4 centimeter. Collection stones are associated with increased risk than pelvic stone, and sepsis-related complications have increased overall. Coming to colonic injury, it's an extremely rare complication. Less than 1% of procedure, can be due to various reasons. Patient with high risk should undergo pre-op CT scan. Early detection, timely intervention, and appropriate care is key to successful outcome. So what are the risk factors? Lateral access to kidney beyond posterior axillary line, more common on left side with lower pole access, retrorenal colon, anatomically distorted kidney due to renal abscess, scoliosis or previous renal surgery, chronic constipation or dilated bowel loops, ectopic or malrotated kidneys, more common in elderly and patient with low body mass index. So intraoperatively, you can see when you're puncturing the kidney, you can see a change in bowel gush shadow pattern during puncture. It can be confirmed by enhancement of colon by contrast, and we can nephroscope. You can see air bubbles. Post-operatively, patient can present just with tachycardia, leukocytis, alias maybe little pain here and there, or you can have a frank blood from rectum, pneumoperitoneum, or feces presented with frank peritonitis. The key word is go and immediately open it and save the patient. Missed injuries can present with localized abscess or nephrocolic or colocutaneous fistulas. Peritonitis may or may not be there. So generally, diagnosis is usually elusive. We have to really think of, because of the variability of symptom and sign, can occur immediately or several days after the procedure. You can, if you have kept a nephrostomy, which is rare nowadays, you can do antegrade nephrostogram, or a CT scan can give you show you the transcolonic passage of PCN tube, or you can see the feces there or air gas there. Treatment approach depends upon time of identification, extent of injury, clinical status, spread on bowel content, or localized. And the classic triad is antibiotics, bowel rest, and separating bowel from urinary tract. I thank Paul sir for sharing this. Has been very kind to share this presentation. I think it's very famous. Many of you must have seen or regular in the urolithiasis section. You can see a very small stone. As I was mentioning, most of the things happen in a small stone, and you can see a feces coming in one of the nephrostomy tube, and the clear and the pinkish urine in the other area. So bowel rest is given by giving nothing by mouth, nasogastric tube aspiration, and intravenous fluid for a few days. Once stabilized, you can start semi-solid and clear diet. I can see the nephrostomy has been pulled up in the colon so that the medial wall of the colon can heal. And if the injury is identified intraoperatively, you can same time keep the nephrostomy in that loop itself, and you can decompress the system by putting a PCN or a DG stent. So triple antibiotic, as I'm mentioning, we will give a cephalosporin, amikacin, and metronidazole is a good treatment for this. Monitor the output both from the, if you have kept it from your nephrostomy or the colonic drain. And this is on 4th postoperative day. You can see a connection between the pelvic erectile system and the colon, and you can see you can place the DG stent here. So you can, once it's stabilized and you put a DG stent, you can put the drain into the colon, or you can, if it is good, you can put it beside the colon so that the wound can heal. And this is solid feces coming. Generally, you can reach 5 to 7 days in this stage. You can always dilate it so that you can remove the any collection there, and antibiotics should be given for 5 to 10 days. And this is the final presentation. Thank you, Paul sir, for sharing this presentation. Most of the colonic injuries are extraperitoneal. They respond to conservative treatment. Intraperitoneal sepsis, immediate exploration, high index of suspicion, triple antibiotics. Suppression of bowel and urinary tract is very important. Delayed diagnosis, you take a general surgical consult and plan accordingly. Next coming injury to pleura and lung is the next common complication. This is just to show you the lung is very close to the 10th rib. And 11th and 12th, you can see the intercostals, we have only pleura there. Incidence is 1.8 to 3.1%. Upper pole axis have a more chance of hydrothorax of 5.8, whereas the lower is only 1.5%. Supracostal puncture, risk of injury to both lung and pleura, puncture always in avoid above 10th rib enters to the PCS. Intercostal puncture should be made always in the upper margin of the rib, because in the lower margin the vessels goes, and when you're coming from supracostal above from a roof, it should be performed lateral to the mid-scapular line. This is a patient with a high up kidney, supracostal puncture done, 11th rib, and the chest was clear under fluoro. This is a method to case which you have 20-30 minutes. It's not a very big stone. Even sometimes in big stone, if you see under fluoro, you will not find anything immediately, but later on you always find some collection. So should be detected on fluoroscopy. If not detected, always do chest X-ray in all cases of supracranial access. I always do that every day. So splenic and hepatic injury, they can see if there is splenomegaly or hepatic is large liver. So if the kidney is accessed above 12th rib, so it's better to be below it. And in case of a splenomegaly, hepatomegaly, you can do ultrasound or CT. And this is showing a mucosal tear and perforation. Sorry, this can happen with overzealous fragmentation of stone. Sometimes when you're trying to remove the clot, your forceps graze the mucosa, and when you're pushing with a hard stone, you're pushing against the inflamed pelvic wall, you can perforate the pelvic wall. There you can see suddenly, you will see there's a collapse of the system. Very common. I'm sure all of us has faced this. These are neuromusculoskeletal complications. These are related to the position, prone positioning. They have reported of visual loss, facial nerve injury, and cerebrovascular accident has also had happened. So you have to do a careful feeding of the patient. You have to do the position guarding all the bony points is very important. This is a lady who has underwent open pilototomy 7 years back and presented with left lower pole stone. So we do a stone guided lower calyx puncture, looks like a residual stone. So 25 ampulas was there, underwent minipec, trying to spec the upper calyx from lower calyx, and heard a cracking sound. And you can see my scope has got broken at 2 places. So because of the open pilotomy, the kidney was fixed. So this sort of complication also happen when you're trying from go to lower to upper poles. You have to be very careful. You can damage your scope also. Related to surgical volume and PCNL outcomes, it has been reported now that volume, more the volume, better is the outcome. This has it has seen that the mortality is increased in centers that perform less than 9 cases per year. For optimum result, centers should perform at least 3 cases per month. Course data have revealed that high volume centers have lower complication and lower length of stay, less length of stay, as well as better stone-free rates. This is the famous Clevin-Dindo classification, grade 1 and grade 2. There's not much difference, only blood transfusion and TPN comes in grade 2. Grade 3 is when you have to take the patient for the intervention. Suppose you put a chest tube in under local anesthesia, it will become grade 3. But if you do some intervention like putting a DJ stent under anesthesia, then it become grade 3B. And the 4B are the life-threatening complication with single organ dysfunction. 4B is multi-organ dysfunction, sepsis, and fear of death of the patient. And D is you add when there is a disability added to the patient. This is just to give you a brief revision of the thing. Now, external stone migration. Many times it happens when your assistant is not hopping the ampulas properly, or when you are fragmenting and the stones have gone outside the system. Don't try to chase it, leave it there, mentioned in the discharge card, because if you try to chase it, you will do more injury and more harm. Post-operative persistent nephrocutaneous leakage is very common now. We are doing more and more tubeless things. So if a small fragment has slipped down, and generally we see that it settles down in 6 to 12 hours of nephrostomy removal, but sometimes it is more than 24 hours. So if you're not put a DJ stent, put a DJ stent, and sometimes if the DJ stent is there, there are a lot of reflux of urine. If you put a Foley's catheter, it settles down. Infundibular stenosis, I was thinking Tanuj has presented one slide from the Dr. Yadav CA where he has shown infundibular stenosis. I also had seen one case who has been operated, reoperated many times and seen inflammatory stenosis there. This happens because of prolonged operative time, large stone burden requiring multiple remote procedure, extended post-operative nephrostomy drainage, recurrent UTI, open pyelotomy, diabetes, and there is a scarring, and patient always come with a pain, and you will tell him, why there is no stone, but actually he's suffering. If you do a proper CT or IVP or RGP, you can see that now since flexible is available, you can do a RARS and you can manage, you can cut that part with the laser. And renal dysfunction is not uncommon. This is because of other operative complications, which has seen that when you are doing in a compromised system, transient increase in creatinine occurs in less than 1% of patient after PCNL. And this is similar to the patient undergoing extracorporeal shock lithotripsy. I was remembering there was a discussion going in the chat box about the renal scarring in patient with single or multiple percutaneous action plate amount to less than 1% of total renal parenchyma. So this was to conclude that session about the scarring, which was being discussed, or the needle puncture and the tract. So systemic complications, it can be have fluid overload. It can be because of going operative time more than 90 minutes. You are using hypertonic fluids like glycine, avoid vascular injury and avoid high pressure irrigation. Extravasation is seen when there is an injury to the system, there is a dislodgement of efficiency, or you have not placed a drain and after a long surgery where there is a lot of collection there. Venous thrombosis is less than 1%. You can diagnose by duplex ultrasound. And if the patient is high risk, you can use elastic stockings. And even recommendation is you can use IVC filters also beforehand if you're planning such a patient. Infection and sepsis, I think, is the most common after I see a colonic injury, which is a great concern, thoracic complications, and now very common is fever after PCNL, 21 to 32%. It's not common only in RARS, but also in more and more mini PCNL, long time we are taking. So this complication, fever has resurfaced in PCNL also. Sepsis has been more than 5%, and septic complications is refractory hypertension, mortality can be very high. Manipulation during surgery liberates bacteria and endotoxins, which can absorb pyelovenous and pyelolymphatics and pyelotroph. So antibiotics very important. I think Sumit presented this well. Risk factor for infection is Staghorn calculi, immunosuppression, diabetes, advanced age, CKD, obstructed system, long duration of surgery, high pressure irrigation, and visceral injuries. All this can high risk of the patient. So ideally, the urine should be cultured and it should be sterile before surgery. Appropriate antibiotics. This has been seen in core studies also. They have found that the patients who have been started prophylactic antibiotics have less fever, higher stone-free rate, less complications. That is very rare. I think it's a nightmare to have a death from the PCNL, but it do happens. And death after surgical intervention for nephrotosis incidence is less than 1%. In the Clavian, this core study, they have 2 deaths and this is grade 5 complication reported. And death is generally due to pulmonary embolus or myocardial infarction less than 3% or severe sepsis. These are the 2 main category where the death is occurring. So urosepsis is absolutely leading cause of mortality, which we have to be very careful. I acknowledge Paul sir for sharing these slides. Thank you very much for giving this opportunity. Thank you very much.
Excellent, Dr. Harpreet. You have covered so exhaustively almost every conceivable complication in such a short time. It should have taken the whole day only on non-bleeding complications. Excellent talk, very exhaustive. Now, let us invite Professor Samir Trivedi for his comments about whether to use PCN nephrostomy for stopping bleeding. Professor Samir, are you there? Anyone else? If Samir is not there, anyone else can express his views about use of nephrostomy for stopping bleeding, nephrostomy tube.
It has a role only in the tract bleeding, but no role when the bleeding is from the pieces. Maybe very little role when we have reviewed the literature. Tract bleeding, they say that you can do that tamponade thing, but I don't think you can stop the bleeding otherwise.
Practically, while placing a nephrostomy, always put a nephrostomy less than what the tract size is. Or if we dilate a 23% tract, the nephrostomy what we is less than what the track size is. So it takes some time to get a tamponade effect on the plot. But if it's a torrential arterial bleed, it won't help. If it's a minor capillary bleed or some venous bleed, then definitely there is a role of for me in compact system.
Dr. Niranjan, anything you would like to say, add on?
The arterial bleeding will not be dealt with only by nephrostomy. Only some venous and capillary bleeding from the tract can be managed. It is nowadays it has less role in management of bleeding. We don't give tubes, and bleeding also generally heals by its own.
Let us come to a practical situation. You have finished a PCNL nicely, and when you want to come out, and if you want to come out, you have removed the nephrostomy tube and it starts bleeding. Sorry, implant sheath. Once you have removed the implant sheath, it starts bleeding. There is a continuous gush of blood coming from that wound.
So we have to do bimanual compression for 5 minutes and see whether this compression helps in stopping the bleeding or not. Then only we can. The other parameters has to be dealt with, whether there are any metabolic complications, whether if the surgery has taken a long time, patient may be hypothermic. These also can increase the bleeding. We can also give a tranexamic acid also to see if it does not help. Then we can give a nephrostomy tube.
So I would like to add on, sir. I would like to add on. In such scenario, one should always keep an eye, as you have already taught us, that we have to keep an eye on the pulse rate of the patient. So one can gauge whether the bleeding is torrential, whether there is a tachycardia is there. Always keep the other eye on the output. If it's a clear output, then nothing to worry about. If it's completely hematuria is there, then one has to worry. Otherwise, tract bleeding can stop just by putting compression for 5 to 10 minutes after removing of the ampulas. If the urine is clear and if there is no tachycardia, one can be happy and control the bleeding just with compression.
Sir, can I say something?
Please. Anyone else? Yeah. We have so many experienced people. Vijay, please.
Nephrostomy has got role in the tract bleeding only. There is no role of nephrostomy, bigger nephrostomy or anything.
What do you mean by tract bleeding?
Tract bleeding means I have a case scenario. If suppose you did PCNL and next day or day after, I mean after 6 hours, you open the nephrostomy, there is lot of blood comes, 500 ml, 1000 ml sometime, mixed with urine. You stop, you again clamp the nephrostomy, and again after 24 hours, you open the nephrostomy. There is again gush of blood came from the nephrostomy. But there is no hematuria, nothing symptom, no symptom to the patient. If you clamp that nephrostomy again and leave it for 7 days, then you open it, there is fresh urine comes and you remove it. I think that is tract bleeding, and that nephrostomy has got role in stopping the tract bleeding.
Dr. Vijay, we were discussing the tract. Where is the bleeding, whether it is through the muscle, through the skin, through the fat, or through the lumbodorsal fascia, whatever is on the tract. That tract bleeding, yes, it can be tamponade. But when there is a bleeding from the renal parenchyma, it may be either venous or arterial. Arterial bleeding, you cannot stop. Venous bleeding, you have to really compress close by. Even when we are doing open surgery and there is a venous bleeding, oozing starts, we press it for some time and it stops. But that pressure has to be 1:1, very close. Is it possible with the nephrostomy tube?
No, not at all, sir. Not at all.
Nephrostomy tube will always be smaller than the tract size, what the implant sheath you had put. So it will continue to bleed. So this question comes up very often. Therefore, I wanted to discuss with so many stalwarts sitting here. I thought Harpreet was speaking something, but he was muted. Harpreet.
No, sir, I was just sharing that no nephrostomy can stop the bleeding. It's only if there are what happens is there are only small vessels. When you block it, there's a tamponade take because it gets clotted. So there are small bleeders. Generally, they stop by that tamponade. But if you have some major bleeding, it will never stop by tamponade. It will start going through the DJ stent to their or urinary catheter to the bladder, and patient will have clots and the clots colic. Only a small bleeders which are here and there when you use generally what if you're using a in conventional 20 to 24, we generally put 14, 16, 18, and this sort of things stop. And when you give a good stitch or a good bite over it, and the most of the tract bleeding also stops. But as such, if you ask me arterial bleeding or the venous, it will not stop. It will find it way. वो कहते हैं ना, ईस्ट कॉर्नर्स छपता नहीं तो वो आ ही जाता है निकल.
I found Dr. Rahul Gupta. Dr. Rahul Gupta is there. He is an experienced PCNL man. Is he there and listening to us? Can he give some comments?
Sorry, sir, you won't be able to see me.
We are not listening to you also.
Rahul, no audio.
Sir, I have one question, please.
Yeah.
I'm traveling, sir.
Okay, Rahul. Yeah, we are not able to listen to you. Vijay, you had a question, and before that, I will conclude this particular talk, discussion.
Yes, I want to ask, is there any role of bimanual palpation in stopping the bleeding from outside? Bimanual palpation from outside.
Do you really believe a renal injury which is bleeding from the parenchyma and you are compressing from both the sides, from the, maybe if the patient is prone, you cannot even put your hand inside, but anyway, if you make yourself unsterile, put your hand and compress it, will you be able to really, do you feel you will be able to compress that hole and stop the bleeding? It is only you don't see.
Okay.
You will stop seeing it coming out. There is a long track. There is a lot of space. There is Girota's fascia, means the anterior and posterior layer of Girota's. Then there is retroperitoneum. Then there are muscles. Then there is fat. So you will not see it coming out. But practically, I feel you cannot, by bimanual compression, you cannot stop the bleeding. Similarly, nephrostomy tube doesn't stop the bleeding, whether it is venous or arterial. And if you want to give tranexamic acid at that time, I don't think it will stop immediately. Tranexamic acid, if you go mechanism of action, it is not going to stop immediately a major bleeding from the vein or the artery. So there is nothing I can see which will stop a bleeding when you remove the implant sheath and it starts bleeding. If anyone else can give any inputs which really stops bleeding and is logical, please. So my concept is that whatever nephrostomy tube we are leaving for a track to be made to get established in 3 to 4 or 5 days, so that tomorrow if there is a big perinephric hematoma and we need to drain it or it has to come out, it will come out from there. Therefore, my indication of leaving percutaneous nephrostomy tube are only 3 if there is infection inside, so that the pressure will always remain low and there will not be any septicemia, it will not go into circulation. Secondly, if there is a residual stone and if I have to come once again to have a look. And thirdly, if there is a hole in the pelvic ileal system, and it may create a urinoma, because the track, if once your track gets formed, after 3 days, if you remove the nephrostomy, if there is any collection, it will drain out. Immediately, if you remove your implant sheath, it may collapse, everything will collapse and urinoma will form. So if there is a injury to the pelvic ileal system, I will leave a nephrostomy. Otherwise, I don't leave a nephrostomy tube and patient is very comfortable. It is the nephrostomy tube which causes pain post-operatively. These patients, I think you will agree, they don't have much pain. Rather, patient under GA, when they come out of GA, they will not mention about pain in the loin. They will mention they want to pass urine. I think you will agree with me. Any other comments? Dr. Chandra?
This discussion go on and on. I am a strong pro for keeping nephrostomy. I have a feeling that this nephrostomy, a small bleeder vein arterial anyway, it will not stop. It will have some pressure effect, little, but I cannot support that. Even if some bleeding is there, I will keep it. But more nephrostomy is useful when PCS is injured, medially pelvis wall is injured. It becomes safe for 1 or 2 days. So for bleeding, it is always controversial. Torrential bleeding, this is the first time I am listening that perinephric hematoma can come out that tract. That is the only logical thing. But we cannot say that nephrostomy will prevent the bleeding, sir. Bleeding will not stop with nephrostomy. It is only for control on the PCS after 3 hours clamping, opening and seeing, and then nephrostogram or relook procedure. These things it will be more useful.
Okay, the question is coming if there is a sepsis, once you aspirate and there is a turbulent fluid. Abhijit mentioned that you should do it a staged procedure. Is he there now? What will you do, Dr. Rajkumar Sharma? If you see the turbid urine?
Sir, on initial puncture, if we see turbid urine, there are 2 causes of it that are common cause. First, if you see a Staghorn stone, or if you see a matrix type of stone, then you may get some turbidity because of a stone. So these turbidity will wash away after if you give a flush from the lower, ask your assistant to give saline push from the lower ureteric catheter. So you can proceed in this type of case easily. But if you get a frank pus, then what I do, I dilate up to the maximum that I can do, up to 20-24 French. Then if possible, if stone is small, then a pickup stone is there, I remove the stone and keep the nephrostomy. If it is very big stone, Staghorn stone, and it's difficult to remove the stone, then it's better to give the this nephrostomy tube and do a stage procedure.
I can give 2 studies, one by Hosseini and one was done at All India Institute of Medical Sciences by Monish Aran. When you, in a Staghorn case, if you aspirate and if there is pus, if there is turbid urine, you send it for culture and sensitivity. Then you have 2 options, either to proceed or to leave a nephrostomy tube and come back again sometime. Both these groups, they studied in those patients where they proceeded and in those patients where they staged the procedure by putting a nephrostomy. And ultimately they mentioned that about 40% of this time, the urine which was aspirated and it was turbid, there was no infection. The culture came sterile. And in All India Institute of Medical Sciences in Aaron study, 70%, to be precise, 68% of the time, the turbid urine was sterile. So there was no extra benefit by leaving and doing a stage procedure. And when they compared both the arms, in both these studies, there was not much difference. But to be on safer side, medico-legally, it will always be better if there is a lot of turbidity, if there is a thick pus coming out, then you stage the procedure. Otherwise, if the stone bulk is less, you can continue and finish the case, and there won't be much difference. I am sure there will be a lot of difference of opinion, and I would welcome if somebody really contradicts that and gives me some logical answer. Anyone, please.
Kalyan Ram is also there from Mahatma Gandhi Hospital, Pondicherry. Can comment.
Please invite him.
I see Pankaj Meshwari also.
Working in a government institute, he will be seeing a lot of stones with infection. A comment from Kalyan Ram, sir. Unmute.
I think it's better to be on safer side, because you can be heroic. One case will change your whole life. So I think it's better to be on safe side. And if any perceived aspirate, frank perceived aspirate, as I think Dr. Raj Kumar Sharma told already, it's better if the frank procedure, you have to stage the procedure. Studies, most of the times they will tell that 70%, 60%, but even 1 in 100 cases will take your life, whole life it will haunt you. That's my opinion.
Okay.
Yeah, we were asking, I think somebody you mentioned is there on the...
Pankaj, sir. Pankaj,
yeah, Pankaj was there.
Pankaj
are
was
you
on...
there?
Yes, sir,
yes,
he
sir,
is there.
I'm there.
He is there.
Pankaj, you concluded this session. Yeah, this session was there in Percon also.
Yes,
So
it
let
was,
us
sir.
listen to your comments.
Sir, it has been an excellent session, a great learning experience. Just about the pus aspiration that was discussed, I would agree with Dr. Kone, where he says that if you find pus, it is always better to stage. Yes, we can proceed in occasional situation, but in our situations where we want safety first, if you have thick pus, better to stage and come again another day. You don't lose anything in staging, but if you try to do something and if even one patient has gram-negative sepsis, then we can land in a huge trouble.
Okay, so consensus is most of the people are interested in staging the procedure. And yeah, definitely the death occurs in Staghorn always with sepsis only.
True, sir.
Most of the cases.
I have reported one patient who had all 4 limb gangrene due to gram-negative sepsis post-ureteroscopy. And this was, though you cannot compare ureteroscopy to PCNL, but once you see such type of complications, the real desire to finish the case in one stage goes down, and you feel safety becomes much more important.
Dr. Kalyanram, you were saying something.
That when I started my MCH training, our chief, Dr. Santosh Kumar, told there is always a second chance in endoscopy. Don't try to finish the whole procedure in single stage. Staging is very important, and you can come on always on some other day.
Yes, if you survive, you can fight another day.
Yes.
That is
Actually,
always there.
Lot of juniors are there on the screen, so gives a good message at the end. I am happy. Many of the juniors are on the 87, 90 people are there. So if the pus is there, benefit of doubt nephrostomy at an earlier stage where clinical acumen is not that high, put nephrostomy and then come out. I also agree, sir.
Historically, if you see, the PCNL was a procedure which was always a staged procedure.
Yeah.
Earlier surgeons, they used to do in several stages, dilatation gradually increasing till the stone size, and then they used to pick up the stone. Our generation, when we started doing it, again, the lithoclast was not there. We were using ultrasound. That was also not very effective. And then people used to do multiple stages. PCNL is the only technique which can be stopped at any stage of your procedure. At any stage, you can abort the procedure, leaving a nephrostomy, and you will wonder the second stage is always more comfortable and more productive. You will do a better job in the second stage or even in the third stage. So let us conclude this with this session. If there is bleeding, if there is infection, if you are scared, if there is a perforation, anything, you should stage a Staghorn and play safe. Thank you very much for listening to this particular symposium on Staghorn. And I hope it will not scare you away. You will get more stimulation to do Staghorn stones and enjoy doing PCNL and managing these cases. Thank you very much for joining us.
Sir, vote of
Good
thanks
night,
is there.
and thanks to all.
Vote of thanks is there.
Yeah, please.
Sir, I'll
Vote of
quickly
thanks by
finish.
Dr. Chandramohan.
I know it is it's time already. Usually 20-30 minutes extra time will be there in webinars irrespective of so much planning. And nearly 80 participants are there. I must thank USI for taking initiative to make the subsection and making Dr. Pal sir the leader of this program, and Dr. Preet Singh and myself and Sarshavardhan as conveners. And as it was planned physical but could not be done now, we have done today. And with President addressal and Keshavamurthy sir addressal, it started, and the moderators are really contributed for the discussion and answering the questions. Abhijit Patel has explained very well with scientific data. Rajkumar has explained the stone has the infection inside. Be careful. Neetu Verma said that sometimes war, we don't play the war, you may win. And next session too, Sumit Kumar to really elaborately explain CT contrast, and then nuclear scan role in evaluation of the Staghorn. Aditya Sharma more focused on the puncture technique. Myself did on ECIRS. Tanuj Pal Bhatia, few examples how RIRS can help. Harshavardhan has gone selected some cases and shown the videos. Harpreet Singh, as SK Pal sir said, has gone in depth. It is a big topic. And at the end, always SK Pal sir takes time to for the concluding session. Few of the like Pankaj Maheshwari, Kalyan Ram sir, and others have participated. They are all there up to 9:50, nearly 10 on Saturday. Overall attendance was average 170 plus or minus. Maximum attendance was 224. So I thank all the moderators, speakers, the audience, and the particularly seniors who have contributed in the discussion. Thank you once again. Good night, everybody.
Thank you.
Thank you.
Thank you, everyone.
Thank you, Harpreet Singh sir. Thank you, Pal sir.
Thank you, Chandramohan.
Harpreet, you have covered it so well. You have really burnt midnight oil. You should have been the first speaker, given all the complications so nicely, precisely.
Yes, sir.
Thank you, sir.
very much. Thanks to all the speakers. Everyone has done justice.
Yeah.
Thank you very much. Good.
I'm sure this will be recorded and kept in our USI website.
Okay, good night.